Kamusta kayong lahat? Ito na si Dr. Jerald.
Hi everyone. Good evening dyan. Good morning sa akin. Ang dami ng participants How are you guys? Antok pa. Good. Parang madaming board examinees. Actually, napaka-challenging nito kasi hindi ko alam actually, to be honest, kung ano yung topic na ibibigay ko. Kasi I have a varied audience. Mayroong PGIs, may clerks, may magtitake ng board. So, yan. Kailangan hati-hatian ko lang. That's why I decided na going mixed, basic with correlates para kahit paano makarelate yung mga gagraduate at PGI sa magtitake ng boards. At the same time, mas makaka-relate yung mga magtitake ng boards. Although tapos na kayo ng basic sciences, sana makorelate nyo yung pag-uusapan natin. Yun. Sana. Hindi ko na-review lahat ng slides kasi ayun, sobrang busy din sa research. So, pasensya na kayo guys. So, let's just learn together. Ang dami na. Nakakahiya naman. I am very unprepared. Abby, go signal ka lang kapag okay na mag-start. Saglit lang guys, may kukunin lang ako laptop. Ay, sorry, tapos na po mag-break? Sige, sabi lang kayo kung mag-pray na.
Nag-start na kayo, kuya?
Hindi pa, gang.
Nawawala-wala wifi namin. Saya.
Okay lang, inaantay ka namin, no problem. No rush.
Sorry, okay. Ayan, I'm wrong. Nag-pray na kayo, kuya?
Hindi pa din.
Okay. Before pala mag-start, i-share ko dito sa chat yung link ng PowerPoint ni Dr. Jerald last webinar natin. Lalagay ko na lang dito. Ayan, nandiyan na siya. Nandiyan si Kuya Ken. Kuya Ken?
Yes, nandito ako.
Right.
Buti na.
And naka-live din pala tayo sa YouTube, guys.
Wow, social naman.
And
Nakakaya naman
pala,
yun.
special thanks to our host. Kaya marami tayong nakapasok ngayon kasi nga, pinahiram niya yung kanyang premium na account. Isa siya sa host ngayon, si Ma'am Yana.
How? Thank you, Ma'am.
Yana.
Thank you, Ma'am Yana.
Ayan. Mamiana Calpatura. Okay, so para po sa mga hindi pa nakakalala kay Dr. Jerald, baka may konting introduction.
May ganun.
Ayan, so siya po si Dr. Jerald Pelayo. Graduate po siya ng UARM batch 2016, tama? Tama, kuya?
Tanda ko na.
Ayan. And dun din siya nag-PGI. So currently, siya ay internal medicine resident sa saan nga, Kuya Ken?
Sa Einstein Medical Center, tama ba kaya?
Back to Kuya.
Hindi guys,
Ayan, so, ayan, kaya super thank you, Kuya, for giving us this time.
Sure.
Para
No
nga,
problem.
ayan, kapagturo ka sa amin. So, ayan, remind ko lang guys, nasa group chat, nasa chat na yung link ng PowerPoint last time. Okay, so let's start na. But before we start, let's bow our heads for a word of prayer. Clear ba ako? Okay. Okay, let's pray. Our dear great God, loving Heavenly Father, we humbly come to thy holy presence, Lord, to thank you for giving us this another opportunity to learn together. May you especially guide Dr. Jerald as he teaches us tonight, and may you also prepare our minds and our hearts, Lord, for the things that we'll be learning. May you please forgive us all from all of our sins. In Jesus' name we pray. Amen.
Amen. Wait lang guys, may tina-download akong
Take your time, Kuya.
yeah. Kasi parang nawawala yung share screen ko na advanced. Tingnan ko nga. Mag-open to. Anong nakikita nyo sa screen? Wala.
Meron po.
Anatomy and correlates.
Anatomy and correlates.
Ayun. Wait lang. Okay. Presenter view, nakikita niya?
Yes, Kuya.
Okay. Yan yung hindi. Gusto ko lang i-download to sa kabilang. Wait.
Sabihin mo lang, Kuya, pag start na para mag-screen record na kami.
Okay.
Okay. Thank you.
Wait. Sure. Kasi nawawala yung aking... Very shortly. Wait. Give me 5 seconds. I'm very sorry, guys.
Okay lang.
Saan ang charger nito? Tulog pa kasi yung asawa ko, yung techie. So, nagkakagulo yung light. Ito na. Give me a second. Sorry, 15 minutes late na. Yan. Pasok mo na yung iba. Sige, go. Malapit na. So as what I have said, wait lang, hindi mo to start. Pasensya sa mga magtitake ng boards. Alam ko may second part kayo. Itong presentation na to mukhang hindi ganun ka applicable for you guys. Pero may pathology naman konti. May konting pharmacology. So kahit papano makaka-relate pa rin kayo. Medyo hindi nga lang talaga like ID, nephro, yung mga applied sciences. Since I have to cater to the needs of everyone, may mga PGIs, may mga clerks. So I will try to do basic correlates of basic sciences. So I'm opening up just some PowerPoint sa kabilang slide, kabilang computer kasi hindi ko makita yung presenter view ko. Alam niyo naman, I haven't memorized everything. And I have notes na nilagay ko like 3 years ago. So hindi ko na maalala lahat. I'm sorry guys. Okay. Si Christine Lucine. Hi. Nakita tayo ulit. So what we'll be doing today, it's an interactive lecture. So kung meron mga questions dito, you can try to answer on your own. Alam ko, di ko maririnig yung mga sagot nyo. Pero it's important that you try to answer. You try to remember the things that you have learned in your basic sciences previously, especially sa med school. As what I have said, always start with the basic sciences. And once you master them, madali na lang yung second part ng board exam. Sa mga magtitake, as a mag-graduate pa lang, this is the best time to start recalling your basic sciences and answer questions every day, especially sa mga magtitake ng board exam. Yun yung lagi kong sinasabi. It's a skill. So, hindi enough yung magbabasa ka lang tapos feeling mo ready ka na for the board. So, kailangan talaga meron kang practice because that's what I've said. It is a skill. Answering question is always a skill. Okay? So, yeah. So, third time. So, 8. Yeah. So, always start with the prayer. So, alam naman natin, we can always do all things only through Christ that gives us strength. So, don't forget that ultimate secret of your success. Kahit anong gawin nyo, without Him, I don't think you will be successful. So, okay, remember this one today as we start moving on. And this is my prayer. Lord, I set aside all thoughts of doubt and fear about the exams as I choose to hold on to your promise that with you, I can do all things. Okay? So, yeah.
The one I gave you for your handout.
Yeah.
The book sent.
Someone is not muted. Okay. So if ever you know this lady, this is Wilma Rudolph. Sobrang unfortunate na kanyang childhood. Just look at that. At age 8, ang dami niyang physical disabilities. Meron siyang polio. She wanted to try basketball team, but she was discouraged kasi nga she's physically disabled. But look at that, she became a champion in one of the Olympic Games in 1960 marathon. And when she was interviewed, this is what she said. Winning is great, sure. But if you're really going to do something in life, the secret is learning how to lose. So sometimes, meron tayong mga magkakataon sa buhay na we lose, but that doesn't mean you're defeated. Okay? If you can pick up after a crushing defeat and go on to win again, you're going to be a champion someday. Okay. So let's start where we are right now and use what we have and do what we got. Okay. So remember that doing your best is more important than being the best. Okay. You don't have to compete with others. Just try to do your best. So today we will try to learn things. Let's do our best to grasp these things. Kasi ako, nakalimutan ko na rin yung iba dito. Kaya I had to use, slides with me. Kailangan ko to. Okay, so I always start with embryology and histology for basic sciences. It's always important to recall saan nanggagaling ang lahat. Kasi all the abnormalities, kapag alam mo yung embryology, medyo madali na lang. Although, of course, embryology is one of the most complicated concepts nung med school tayo. Okay? So, first question, when is the sex first determined? Sometimes we think 4th week, 10th week, 12 weeks of gestation, or 16th week of gestation, di ba? Yun yung usually sinasagot natin. Pero back to the basic question, when is the sex first determined? My tip is always look at the question very carefully. Don't overanalyze. And sometimes meron tayong mga preconceived ideas about the answers to questions. The question is not about kailan makikita sa ultrasound. Okay? Ang tinatanong is when is sex first determined? And the answer to that question is during fertilization, right? Once the X and the Y, or the X and the X combine, then alam mo na, it's a female, XX, XY, male. Okay? But the gonads have to go through different stages. Okay, this is very important. So it starts with the primordial germ cells lining the yolk sac. That's why yolk sac is very important as far as development of the indifferent gonads. So we have indifferent gonads, as you can see here in the blue line. Okay, and they're formed in the urogenital ridge. Okay, and this is composed of the intermediate mesoderm. Okay, these indifferent gonads will undergo mitosis, and then with the help of these hormones and factors, they will differentiate. Okay, and I hope you still remember these ducts that will form the ductal system of your reproductive system. Mesonephric is for the female, right? M for M. Kung hindi nyo maalala yan, wolf is for male, right? Wolfian duct, male, mesonephric duct. Paramesonephric duct is the Mullerian duct, other terms. So always remember the equivalent terms. The board examiners usually interchange them, so dapat alam nyo. Paramesonephric Mullerian duct. Okay? With the presence of a testis differentiating factor, TDF, and testosterone, and Mullerian inhibiting, so against the women. So you have a testis in the male genital system. Easy, right? Without all of this, then you have the female genital system. Okay, so remember these things. Primordial germ cells, they come from the yolk sac. That's a very important concept. They travel to the urogenital ridge, and there they undergo mitosis. Okay, and after differentiating, then they have this different genital system. Okay, this is a very basic concept that I would want you to know. Kailangan importante na alala nyo yan lahat. Okay, this one is a summary of the things that you have studied before. Okay, so look at this. In different gonads, with the presence of a testis differentiating factor, you have all of this. I don't need to discuss this. Alam nyo to. Okay, with the presence of TDF. Without that one, the gonads will become this one: ovary, follicles, retiovary. Okay, how about the paramesonephric ducts? With the presence of Mullerian inhibiting. Mullerian is for female. You inhibit the female, you produce the testis, but only the appendix part of the testis. If you still remember your anatomy, you have a testis, and then the appendix is just like a finger-like structure right there. Without this MIF, then you have the uterine tubes, uterus, the cervix, and remember this one, only the upper part of the vagina. Okay, the lower part of the vagina comes from a different structure, and they have to meet at one point, and that certain point should obliterate for it to be patent. Okay, and next one, we have the mesonephric duct with the presence of the testosterone. M for M, male for M, Wolffian duct, other term for that. Then you have this system: epididymis, ductus deferens, seminal vesicle, ejaculatory duct. Without testosterone, this mesonephric duct will become the duct of Gardner. Okay, for the board examinees, these are the common things that you forget. Appendix of the testis and the duct of Gardner. Look at them now, try to memorize while I say these things. So the goal of my lecture is for you to start memorizing and mastering things before the boards. For those who are still graduating, try to just refresh. Okay, alam ko medyo overwhelming to, pero just try to look at them and refresh and try to close your eyes and try to memorize, okay? Then the genital tubercle, medyo madali to. Clitoris for the female and glands and body of the penis for male. This one, another favorite board exam question. Saan ang gagaling sa labia minora? Hindi po sa genital tubercle, hindi sa labioscrotal swellings, but from the urogenital folds. Okay? Ano yung homolog ng labia minora? Another favorite board exam question. Ventral aspect of the penis. Okay, remember, we are talking about the ventral aspect of the penis once the penis is erected. Okay, this is the human body. This is the penis at erection. This is the ventral anterior part. Okay, so if it's not erected, then it is the dorsal part. Don't confuse that. Okay, so ventral aspect once erected. That's the equivalent of the labia minora coming from the urogenital folds. And of course, this is the easiest part. Labia majora scrotum comes from the labioscrotal swellings. And these three structures will mature with the help of a DHT, dihydrotestosterone, which will only be activated once the testosterone binds to its receptor. Okay? And remember, testosterone can be converted to estrogen as well. So females, you can have testosterone. This can be aromatized by aromatase, right? If you still remember. That's why you have some hair. It depends on the amount of aromatase that you have. And also, males, you can have estrogen as well, with the testosterone converting to estrogen via aromatase. That's why some have gynecomastia. Okay? Let's try to answer this question. You are given a patient coming in with an ultrasound of absent uterus or upper vagina. Okay, so if you look at this, you try to recall what's the duct that is absent. The upper vagina is absent, so you think about the female, right? However, the karyotype is XY. Absent paramesonephric duct, so likely you're thinking about predominance of a mesonephric duct. So male over female, you have a cryptorchid testis, not descended. The clue here is you have a karyotype XY. That's basically a male. This is a male patient. You have breast development. Okay. You said, sir, testosterone can be converted to estrogen via aromatase. So there is a testosterone acting. However, you see that the pubic hair is minimal to absent. So likely that the dihydrotestosterone is not activated. Is there a problem with the testosterone binding to the receptor? Likely. Okay, this is not a female, no paramesonephric duct, no Mullerian duct. You have a testis, that's why you have an XY, right? So this is likely a patient with complete androgen insensitivity syndrome, meaning you have a testosterone. Okay, unfortunately, the receptor of the testosterone or androgen is actually mutated. That's why instead of binding to the receptor, this testosterone is converted to estrogen via aromatization. That's why you have a breast development, okay, and you have absent or minimal pubic hair because the dihydrotestosterone is not activated. Okay, sounds good. This one is an easy problem. You have a female patient, of course. This is confirmed by your XX karyotyping. You have a breast development, okay, and you have normal axillary or pubic hair. But this time, look at this. You have normal ovaries, so you don't have problems with that. That's why you have an XX. You have a breast development because the ovaries produce the granulosa, right? Produce your estrogen. But you don't have any upper vagina. It means that the paramesonephric duct or the Mullerian duct is not developing, but the rest are normal. OBGYN, you know this, right? So this is your MRKH, or the Mayer-Rokitansky-Kuster-Hauser syndrome. right? So you have agenesis of the Mullerian duct. That's why you have hypoplastic or absent Mullerian duct system. Only the upper part of the vagina, uterus, and the fallopian tube is affected, but the ovaries are normal. Okay, so you don't have to memorize. Think about the previous slide that I have. Okay, that's why I told you it's important to understand embryology, to understand basic pathology. Okay, you have another patient, female, okay, XX. You have normal pubic hair, you have normal breast development, you have normal uterus, you only have an abnormal vagina and normal ovaries. So the problem here is maybe the clinical presentation should be a woman with cyclic pain starting the time of puberty or menarche. No menstruation was ever reported, and there's this tending abdomen, or pwedeng sabihin natin every time every month after the menarche, sabihin natin merong mga spotting pero hindi talaga yung full na menstruation, menses. So you think about something that is obstructing, right? As what I have told you, the upper vagina comes from a paramesonephric duct, and the lower part of the vagina comes from a different structure. And I hope we still remember that. If you don't, then we will try to recall that one. That's the urogenital sinus. So the urogenital sinus comes from below. It is responsible for the development of the lower part of the vagina. The Mullerian duct, or the paramesonephric duct, forms the upper part of the vagina and the uterus, and then they meet halfway. Okay, actually medyo upper two-thirds. So they meet there, and there's a septum that is formed. So that septum should be obliterated for patency to happen. So if there's a septum, persistent septum there, that's what you call transverse, TVS, vaginal septum. And that's probably the reason why this patient has problem with cyclic pains and absence of menstruation. So the only problem is abnormal vagina. So classic question. This one is the easiest among all the four disorders of sexual development. You have a karyotype 45X without deficient chromosome for the female or male. Hindi mo alam. Then you have a streak ovaries, and then you have normal axillary and pubic hair with variable breast development. So the clue here is your streak ovaries, right? This is commonly associated with patients. Meron kang web necking, meron kang coarctation of aorta. Okay, so this is very common among Turner syndrome patients. And the problem is you have a complete or partial absence of one X chromosome. Okay, so there was one question interesting that I remember about these Turner syndrome patients. The question was about the second most common congenital heart problem associated with it. I know it's coarctation of aorta is number one, but the number two, I don't know. That's very controversial, but I don't know if you still remember, but the most common, second most common is mitral valve prolapse, or MVP. Okay, so these are very common in actually in adolescent women with panic attacks, with chest pains, and then sometimes they have idiopathic embolic stroke. Yeah, sometimes, very rarely. So these Turner syndrome patients have MVP as well, but the most common congenital problem is the coarctation of aorta. Okay, this one is kind of boring to you. Let's just try to see what we can learn from this. Okay, so remember what I have said, the primordial germ cells, the first slide that I showed, comes from the yolk sac, and they travel to the urogenital ridge, right? And then once they get there, they undergo mitosis, and this is the product. Okay, after mitosis, it means, I hope you still remember the difference between meiosis and mitosis, right? So meiosis, that is the process wherein after the process you have a half of the daughter cells, right? Like 46 divided by 2, that's 23. But in mitosis, you still have the same number. Okay, so they undergo mitosis there, several rounds of mitosis, and then they differentiate into not the B, but spermatogonia type A first. Of course, A comes before B, sorry. And then for the females, this is oogonia. Okay, what is very interesting is for males, actually, once the primordial cells travel to the urogenital ridge, they remain as primordial germ cells until puberty. So very late. That's why males have late maturation age. Embryologically, that's true. So once they reach the urogenital ridge, they stay as primordial germ cells. They even do not differentiate into type A spermatogonia. It remains as primordial germ cells until puberty. Okay? Pero ang mga babae, bida-bida to. Nauuna yan sila lagi, di ba? Kaya ang daming problema. Joke. So, ang nangyayari sa babae, once they reach the urogenital ridge, they immediately differentiate into oogonia. Okay? And even at the 5th month of life, they enter meiosis and become primary oocyte. That's how advanced they are. Even at the 5th month of gestation. Sa loob pa lang ng womb ni mommy, naging primary oocyte na sila. Yung mga lalaki, andun pa lang even sa primordial germs, hindi pa nga nag-differentiate to spermatogonia until puberty. Okay? So, pag medyo mature na sila lalaki, age of puberty, sabihin natin 12 or 13 years of age, this primordial germ cells will differentiate into type A spermatogonia. Itong type A spermatogonia, guys, hindi ito nagpa-participate into meiosis process. They are just, sabihin natin, sila lang yung source or sila yung stem cell to differentiate into type B. Ang type B ang nagpa-participate into this whole process. So type A remains as stem cells, and type B will participate once the patient reaches the age of puberty. Okay? So once they reach the age of puberty, ito na nagiging process hanggang papunta sa meiosis 2. We'll just try to recall them. But for females, as what I have said, they differentiate into oogonia at 5th month of life, and then right after they reach the urogenital ridge, they differentiate into oogonia, and then the 5th month of life, they enter the first meiosis stage. Okay, so look at this. This is 46 number of chromosome. This is 2N, 2 pairs of your chromatids. Okay, so primary oocyte, spermatocyte. Sorry, let's just start with the male. So at the age of puberty, yay, type B will differentiate into primary spermatocyte. Look at this. There's DNA replication. That's why the 2N becomes 4N. They undergo synapses, and then they go crossover, sharing of the DNA fragments, and then they undergo cell division, this junction, which is the main problem in females, in Down syndrome, right? Cell disjunction. So they undergo disjunction, and then the centromeres in this part do not split. Very important because this differentiate between 1 versus 2. So in meiosis 2, centromeres split. In meiosis 1, centromeres do not split. Okay? And then they become secondary spermatocyte. As you can see, if this is meiosis, it means 46 becomes 23. And the 4N becomes 2N. So like half of the number of the mother cells, right? So at the end of the meiosis 1, you have a secondary spermatocyte, but this happens for male at puberty. And this also happens in female at puberty, secondary oocyte. Why? Because at the 5th month of life, sinabi ko kanina, di ba? They become primary oocyte, but they are arrested. That's a common board question. What phase are they arrested? They're arrested at prophase 1, right? So, bida-bida si female, nauunang mag-differentiate into oogonia once it reaches the urogenital ridge, and then it becomes primary oocyte at the 5th month of life, but they are arrested at prophase 1 as primary oocyte. And they become unarrested at puberty. Okay? Pag nag-mens na sila, they will be unarrested. That's why secondary oocyte na po yung mini-mens. Okay? And then, they will become arrested again at metaphase 2. Okay? Unless they are fertilized. So ulitin ko, favorite board exam question yan. Okay? I will retell the story again for females. Okay, from the yolk sac, the primordial cells will travel to the urogenital ridge. Pagdating doon, sasabihin niya, oh, mauna na ako, bida-bida, magdi-differentiate na ako din oogonia. And then at the 5th month of life, papasok na ako sa meiosis 1 primary oocyte. Oops, masyadong advanced. I will become arrested in prophase 1. Pagdating ng 13 years old, oops, nag-mens na siya. I will unarrest myself. Pupunta na ako sa secondary oocyte, meiosis 2. Pagdating sa meiosis 2, oops, and I will be arrested again at metaphase 2. So the first arrest is prophase 1. The second arrest is metaphase 2. Hanggang walang magmi-meet sa'yo na fertilization na sperm cell, you will be arrested at metaphase 2 of meiosis 2. Okay? Pag nag-fertilize na, boom, the meiosis 2 will be completed. Okay? For the male naman, sabi ko sa inyo, it will remain as primordial germ cells until puberty. Very patient. Pagdating ng puberty age, magiging spermatogonia A, which will become the stem cell for spermatogonium B. And then they enter into meiosis 1, become primary spermatocyte, secondary spermatocyte, no arrest in each of the phase. And the result, you have a 23 haploid cell, 1N, gamete, okay? 4 for your male, okay, and then one gamete for your females, 1:4, okay. I hope you get that. That's kind of a story. Now, if this is the question, how would you answer this? What is the histology of a male gonads at birth? Careful. Alalahanin niyo yung story. Okay, sinabi ko kanina, it will travel from the yolk sac, from the primordial cells going to the urogenital ridge, and it will remain as primordial germ cells until puberty. Right? Pag hindi ka nakikinig sa lecture na to, malilito ka kasi parang, ano nga itong spermatogonia, A, B, primordial germ cells? Baka all of the above. Baka mixed sila lahat. Okay? So, hindi guys. Okay? At birth, sinabi ko, they will remain as primordial germ cells. Kasi nga, di ba? They will only differentiate into spermatogonia A at the age of puberty. And the question is about gonads at birth. Right? That is very important. Very basic, but sometimes you will forget. Kasi nakalimutan mo na yung basic concepts natin. Okay? And a second. Next question. What is the histology of female gonads at birth? Yun. Magkaiba to. Diba? So, isipin mo at the 5th month of life, sinabi ni Doc, bida-bida to mga babae, magdi-differentiate agad into goni at the 5th month of life, magiging primary oocyte. Ang tinatanong at birth. So, hindi pa siya nagme-mens. So, na-arrest siya in prophase 1 as primary oocyte. Okay. Malamang hindi letter D, malamang hindi letter C. So, you are left between A and B, primary oocyte. But the thing is, you don't remember if it's 4N or 2N. Right? Okay. So, now try to recall. Sinabi ko kanina, tingnan natin ulit para maalala mo. Primary oocyte, because of the DNA replication, the 46 remains. You have 46 number of chromosomes, but the 2N becomes 4N. That's what you can see, 1, 2, 3, 4. Therefore, the answer to that question is primary oocyte, 46 chromosomes, 4 sets of homologous chromosomes. Okay? Now, very boring. Okay, so you have a secondary oocyte here, as you see in metaphase 2, right? They are arrested in metaphase 2 unless they are fertilized. You have the zona pellucida there that has to be penetrated by the sperm. You have the corona radiata cells. That's coming from the granulosa cells. These are the estrogen secreting cells. They go and travel and reside in the ampulla of oviduct, like the lateral 2/3. And this is the site of fertilization. Sabihin natin na fertilize ka. Woo, boom. Then from a 23 1N, of course, times 2, you become 46 2N, right? That's when the zygote is formed. And then you try to become a blastula, 2-cell blastula. Once you see a cyst, once you see a fluid forming, the blastula is termed as blastocyst. Morula at day 4, you have 16 cell stage. And remember, guys, this is mitosis. This is not meiosis anymore because you duplicate the number of cells, the exact number of a mother, the number of chromosomes from the mother cells. So kung titingnan nyo siya, the cell, the entire cell size remains the same, but the number of cells inside actually duplicates, multiplies by exponentially. Okay? So padami ng padami ang cells, yung size ng buong cell mo remains the same. Okay? Until it becomes a blastocyst. What's the differentiating factor? You have a fluid in a blastula. And then you have two bodies that you see. Okay, major embryoblast, okay, which will form the embryo, and you have a trophoblast, which will form the placenta before implantation on day 6 or day 7. Okay, I hope you still remember your trophoblast, which has two types, right? The cytotrophoblast and the syncytiotrophoblast. The cyto comes from the word cyte or cell. The syncytio, of course, syn comes from combination or together. That's why, so you can see, para silang nagko-combine ng mga cells, and these are the cells that actually come in contact with your uteroplacental vessels. That's why they established the blood supply. But very important, this is a common misconception among students. Which of the two cells actually is mitotically active? Most of them will answer syncytiotrophoblast kasi nga they actually crawl, they actually spread and come in contact with the uterine vessels. No guys, kayo lang makakaalam nito. Okay, it's the cytotrophoblast that is mitotically active. Okay, they produce the stem cells, and then once they have produced the stem cells, they will combine together and become the syncytiotrophoblast. It's just like spermatogonia A, which is the stem cell, versus the spermatogonia B. This time, the stem cell is a cytotrophoblast. Parang ganon yung analogy. They come from the cytotrophoblast, and then they become syncytio once they are combined together and they do their function. Okay, and this is the embryoblast. So once they implant, usually it's the embryonic pole. Okay, ang nauuna dyan. And most of the time, not the anterior uterus, most of the time, nasa posterior wall. Okay, so that's what happened in week 1. So just imagine this concept. In week 1, ito yung nangyayari, fertilization, implantation, and the formation of the two blasts, embryoblast and the trophoblast. So during this time, if the syncytiotrophoblast is already forming, then you remember the HCG, which is produced by the syncytiotrophoblast. You can have positive urine pregnancy test, but likely let's wait for like 10 to 14 days for it to be more developed for the urine HCG to be detected. But as early as day 6 or day 7, they can start functioning. Okay, just a board question. 32-year-old female presents with right lower quadrant abdominal pain and vaginal bleeding. So let's do a correlation with OBGYN. After stabilizing the patient's condition, of course, you have to do that first before any diagnostic testing. The patient could be in hypovolemic shock or whatever, I don't know. She is bleeding profusely, sabihin natin, with right lower quadrant abdominal pain. What is the next appropriate step? Who will order hysteroscopy? Yan, galing-galing. Titingnan mo yung uterus agad. Who will order CT scan? Napaka-invasive, napaka-mahal, especially dyan sa Pilipinas. So let's try to do between A and B. Who will do transvaginal ultrasound? Who will do letter B? Of course, in this case, always rule out presence or absence of pregnancy, right? So that you know what are you dealing with. You are dealing with a gynecologic problem, hindi buntis. Maybe H-mole, even H-mole has high HCG, di ba? Malilin lang ka. O baka may cancer, baka may polyp, baka may cervicitis, di mo alam. Baka appendicitis, baka ovarian torsion. Many things that could come in. Okay, that could happen to the patient. Kung buntis naman, baka abortion, right? Baka ectopic pregnancy, baka H-mole, sabihin natin kasi mataas yung urine HCG by that time. So you have to rule out pregnancy, right? So urine testing to just look at the HCG beta, serum for you to quantify the amount. Bakit kailangan mo ng serum HCG? You want to know the baseline. Kasi pag bumagsak yan, pag nag-serial HCG ka, ay, ectopic pregnancy to. Okay? Kapag pataas ng pataas, ay baka talagang may namumuong gestational sac producing the HCG, the syncytiotrophoblast is active. Or even after removal of the H-mole, we have increasing HCG, na baka mag-transform to ito into a neoplasm. Okay? So that's why the answer to this basic question is order urine and serum HCG. Although yung serum hindi masyado natin ginagawa kasi usually pregnancy test lang, ba? Okay, correlates to ectopic pregnancy. What is the most common form? Tubal, right? If you remember the oviduct or the fallopian tube, that is where the most common site of ectopic pregnancy kasi napakaliit niya, right? not a good site for implantation. But the most common site of rupture in the specific part of the fallopian tube is in the isthmus. Yun yung the narrowest area. That's why once the ectopic pregnancy goes there, then you have a high risk of rupture, high risk of bleeding, and hypovolemic shock. And what are the risk factors? Once you have a previous history of that certain disease, then you are predisposed to have that again. Previous ectopic pregnancy, right? You have pelvic inflammatory disease. You can have scarring right there. You have history of surgery before. You have DES exposure. I hope you still remember the diethyldestrol, which is associated with what pathology? If you still remember your pathology, it's clear cell cancer in the vagina, right? DES exposure. You can also have ectopic pregnancy with that, and in the endometriosis history, what is the most common site of this? It's ovarian, right? So you have ectopic implantation of the the glands, okay, either in the myometrium area, that's adenomyosis, but a different part of, like, even outside of the reproductive system. You can have endometriosis anywhere else, but the most common site is in the ovaries. And during menstruation, they can also bleed, and they can also give you some pain, right? So the clinical triad of ectopic pregnancy, you can have bleeding, you can have abdominal pain, and amenorrhea. Looks like a pregnant woman, right? Bleed, masakit ang tiyan, hindi dinulugo, right? Hypovolemic shock in case of severe bleeding, and cervical motion tenderness upon assessment. That's called the chandelier sign, which is also seen in any other pathology, non-specific. You can have that in cervicitis. You can have that in any other pathology. And differentials is what I have said: abortion, okay, molar pregnancy, H-mole, appendicitis. I have already mentioned this one. Once the patient is stable after just medical therapy, methotrexate, and then once the patient is unstable, then we have to surgical intervention. Okay, sometimes the ectopic pregnancy can go outside of the reproductive system and go into the abdominal area, in the rectouterine pouch, or the pouch of Douglas, which is the most dependent area of the peritoneal cavity, right? So you can also have an ectopic pregnancy there, very, very rarely though. Question: which of the following statements is most accurate about implantation? Okay, let's see if you can still recall. Let's try letter D. Blastocyst implants during the follicular phase of the menstrual cycle. Remember, you have a follicular phase and the luteal phase. The follicular phase, it's the ovarian follicles that's producing your estrogen, preparing the endometrium. After the ovulation, you have the luteal phase, right? You have the corpus luteum already. But the question here is about implantation. Of course, isipin mo, implantation happens after the ovulation. But this is follicular phase. That's why this is obviously wrong, if you remember the menstrual cycle. So letter D is wrong. How about letter C? Where does it implant? In the basalis layer or in the functionalis layer? Remember, you have a functional layer and then you have the basal layer. Of course, the first layer that comes in contact with the embryo should be the functional layer. Okay, so the letter C is again wrong. How about between A and B? That's what I have said. They both implant with the embryonic pole, right? But most of the time in the posterior wall of the uterus. Okay, this is the concept that sometimes are not discussed, are not well illustrated during med school. So now you know it's an embryonic pole, most of the time posterior wall. Okay, so we finished with week 1. So just picture out in your brain what happens in week 1, what are the possible questions that they can get, and what are the complications. Those are already taken care of. Okay, let's go to week 2. Okay, sabihin na natin, nag-implant na siya. This is the functionalis layer. This is the basalis layer as a whole. Now you already have an implanted embryo. Okay, if you can still remember, let's review. These are the syncytial trophoblasts, right? Ito yung mga gumagapang, and they come in contact with your uterine vessels. They establish the circulation. Look at the cytotrophoblast. They remain here as your stem cell for the syncytial trophoblast. Okay, And look at this endometrial blood vessel. Sila yung target ng mga syncytial trophoblast. Remember, HCG is formed by your syncytial trophoblast. Okay, but that is not the highlight of week 2 because these two actually starts to form at week 1. Okay, so let's week 2 the highlight of week 2 is actually this bilaminar disc. Very easy to remember. Week 2, bilaminar. At week 2, you produce 2 blasts. Okay, and these blasts are called the hypoblast and your epiblast. Okay, so they are the bilaminar embryonic disc. That's the differentiation of the embryoblast. I want you to remember that the hypoblast actually is responsible for forming your yolk sac. Okay, and the epiblast for amniotic cavity. Para hindi nyo makalimutan, sige ganito, kalokohan lang to pero naalala ko to ganito. Hypoblast, may letter Y dyan, di ba? Okay. Yolk sac. Epiblast, amniotic cavity. Okay. Kasi minsan nakakalito na ako, saan nga nanggagaling si amniotic cavity? Saan nanggagaling si yolk sac? Okay. So at week 2, you have a bilaminar disc coming from the embryoblast, and the hypoblast will differentiate to become your yolk sac. Okay, they form the primary yolk sac. And I hope you still remember the first slide that I showed you. This is where the primordial germ cells come from, the yolk sac. And also, that is where hematopoiesis occurs. Okay, so at the second week of life. That's why kung tanong ka sa board exam, ano yung first hematopoietic organ in the body? It's the yolk sac. Apart from it being a source of primordial germ cells, they are the starting point of hematopoiesis at week 2. So dyan na nagpo-produce ng blood, starts to produce blood. Okay, so hypoblast, yolk sac, epiblast, amniotic cavity. Okay, so that's actually the two big things in week 2 happening. And also this one, I want you to remember this one. There's a certain point wherein these two this bilaminar disc actually interact with each other. Ito yung sinasabi ko kung saan sila nagkikiss. It's the precordial plate. This is very important because this will dictate where the mouth will form. Okay, the opposite to this is your cloaca. Okay, so the precordial plate, remember that word, is where the mouth will come from. This is exactly where hypoblast and epiblast interact with each other first. So kung isipin mo yung mouth talaga, guys, ang first na ginawa nila embryologically is to kiss each other. Okay, yan, precordial plate, mouth. This is where first contact between hypoblast and epiblast. I will not make things complicated. Yun lang ang kailangan yung malaman for week 2. Okay? Yeah, question for week 2. Even week 1, HCG is produced by syncytial trophoblast. Yan lang sana yung alam mo. Yan pa yung binigay sa question. Dapat sa tinanong na lang, what produces HCG? But the question is more complicated. Which of the following clinical correlations would reveal high HCG level? Yan lang, kagulo na. Just taking strat, abortion, parang hindi ito magbibigay ng high HCG kasi malamang pag na-abort, nawawala yung syncytial trophoblast from the trophoblast, hindi namamatay sila. So you're left with B, C, and D. Ito yung mahirap sa board exam questions kasi minsan mahilig sila sa both B and C, which is not a very ideal way of asking question. Sometimes ganun yung mga lola at lola natin, so kailangan natin i-deal to. Okay? So most of the students would answer this question with the letter D, right? I know some of you would answer that letter D. Pero guys, mali yan. Only the Down syndrome would give you a high HCG level. Okay. Lagi ko itong nakakalimutan. That's why I made a mnemonic. I made this slide. Kayo lang nakakaalam nito about the different differences. Okay? Because we have second trimester screening, right? Although wala dun sa Pilipinas, but sometimes they ask, anong mataas, anong mababa sa mga ganyan. Okay. I will give you some tip. Okay. For trisomy 21, that's your what's this? Down syndrome. So trisomy 18, that is your Edward syndrome. Trisomy 13, that's your Patau syndrome. Okay, the lower the number, the more severe the presentation. So you have this trisomy 21. What is two markers that are high in trisomy 21 is HCG and inhibin A. Para hindi nyo makalimutan, guys. First letter is H, first letter is I. Okay? High level in trisomy 21 is HCG and inhibin. Huwag nyo na memorize yung dalawa. Basta yung dalawang yun, low na yun. Okay? So, ito palaging tinatanong. Okay? For trisomy 18, pareho sila lahat except for the HCG and the normal inhibin. Pero usually hindi yan tinatanong. More commonly asked is the Down syndrome and the neural tube defect. So you have spina bifida, you have gastroschisis, omphalocele. Most of the time, only the AFP is increased. Normal the rest. Okay, so if there's one thing you have to memorize, it's a trisomy 21. High level is HCG and inhibin A, low level A and estriol. Okay, so that's why high, down sana, no? Pero high in Down syndrome is H and I. Low, the rest. Don't memorize them. Just only this one. Okay, if ever they ask you. Now, this concept is very important kasi lagi akong nalilito ng pediatrics. Anong mukha ni Patau syndrome? Anong mukha ni Edwards syndrome? Yung Down syndrome, medyo madali na lang. Kasi, di ba, makikita naman upward slanting, epicanthal folds, mga ganun. Madali lang. Pero itong Patau at Edwards syndrome, minsan nakakalito. That's what I have said. The lower the number, the more severe the presentation, right? So, 13 is worse than 18. Usually, hindi ito nagsasurvive. Ito, medyo, pero namamatay din sila. Hindi sila nagsasurvive to adulthood. So, by presentation, they can be asked in pediatrics. Okay? So, more severe, 13 than 18, right? This time, about the number of fingers. Ano ang mas severe? Yung 6, polydactyly, or nag-overlap lang yung 4th or 5th finger. Okay? So, actually, it's worse. You have a worse presentation of polydactyly than overlapping fingers. So, 13 is for polydactyly, and then Edwards is for overlapping fingers. Okay? Yeah, tried it at 13. Patau, laging patay. Very good. Wait, saan ako? And then microphthalmia is worse than micrognathia. Okay? You only have a small, ito, medyo malilito kayo. Micrognathia is a small jaw. Okay? Microphthalmia is small eyes. Just remember, eyes are nearer to your brain. So, mas maliit ang mata, maliit din yung brain. Mas severe than just the jaw, acute, and a prominent occiput. Okay? And you have cleft palate in Patau syndrome than Edwards syndrome. So, wag na kayong malilito. More severe presentation in Patau syndrome than Edwards syndrome. Okay? Just remember the worst presentation and you will not be confused. Okay. So now try to remember week 1. Okay, implantation. Week 2, bilaminar disc, hypoblast, epiblast, precordial plate kung saan sila nagkikis. And then let's come to the last part of embryonic period and we're done. We will go to the different concepts. Okay? I hope you're still with me. Okay. So, week 3 to 8, na-form na yung hypoblast. Okay, remember this one? This is your epiblast. The hypoblast is the yellow one. And then the epiblast, ito yung brown, ito yung blue. Okay? If you cut this one, ito yung makikita nyo, guys. Do you remember this one? The precordial plate. Okay? Kung saan nagkikis itong dalawa. That is where the mouth will form. And this is the cloacal membrane. Ito yung magiging anus, right? And at the middle, you have the formation of the primitive, all the primitive node, pit, and streak happens in week 3 and 8. Very magical ang nangyayari dito, guys. Kasi itong mga cells, they're just roaming around, circulating, and then going to the primitive streak and node. Okay? And they have a commander right there at the middle. The notochord actually is the commander. Pagdating ng mga cells there, sasabihin niya, okay, go to the side, go back up, or go down. Siya ang magde-decide. Like, go back to the epiblast, go down to the hypoblast or go sideways, okay, to become another layer. So in the week 3, actually ito yung 3, di ba? Formation of the 3 primary germ layers. Week 2 is bilaminar disc, 2 embryoblastic disc layer. This one, 3 layers in week 3. That's why it's called gastrulation. Inisip ko lagi dyan, gastrulation. Okay? 3 layers. So what are the 3 layers na kinamumuhian natin ng first year? Ectoderm. Okay? The epiblast will become an ectoderm, E to E. Okay? The hypoblast, madali lang kasi nasa ilalim yan eh. It become the endoderm. Okay? At ang mga cells na sinabi ni Notochord, dito ka lang sa side, it will become the mesoderm. So this is the time that you have the 3 germ layers. Okay? Ectoderm, mesoderm, and the endoderm. So the common board exam question here is ano yung mga organs na nanggagaling sa ectoderm, nanggagaling sa mesoderm, at nanggagaling sa endoderm. So general concept, anything that is within or inside, any lining within an organ, usually, but not all, comes from the endoderm. Okay? Yung mga in-between, okay? Mga muscles and bones, yan, hematopoietic organs, usually in the mesoderm. Okay? Yung sobrang nasa labas, nakikita mo, fingernails, lens, teeth, di ba? Skin, usually they come from ectoderm. That's the general concept. But of course, there are always exceptions to that. Okay? So we will try to relearn today how to correlate the organs in a fully developed human being to these 3 germ layers. Medyo mahirap, pero I'll try to help you with that. Okay? So remember this notochord, the commander. Remember this primitive streak because they always have correlation with pathology. Look at this. The sacrococcygeal teratoma, if you still remember in your pediatrics, they arise from your primitive streak. And I hope you can relate, oh, so dyan pala nanggagaling ang primitive streak. And usually, the sacrococcygeal teratoma is like at the lower portion of the spine. And it is nearer your cloacal membrane. So it's logical. Oh, malapit sa puwet, kaya pala sacrococcygeal teratoma. Because this is where the primitive streak is located. Far from the precordial plate. Far from the mouth, right? Chordoma, it arises from the notochord. Okay? And the H-mole, as we have mentioned a while ago, is actually a partial or complete replacement of trophoblast with dilated villi. Okay, so it comes from the trophoblast. That's why in H-mole, you have a very high HCG. Kasi nga, trophoblast gives syncytial and cytotrophoblast. Right? Okay, so OBGYN, ito, medyo madali na to. So you have an H-mole, you have a 46 XX or 69. Okay, you don't have any embryo. So malamang absent siguro yung ovum, empty, and then nag-penetrate si sperm, and then the sperm actually duplicates or have mitotic development from a 23 naging 46, pero purely paternal lang talaga siya. Galing lang sa tatay. Kaya minsan XX, minsan XY. But most of the time, look at the number. Ito yung weird kasi complete siya, complete H-mole, pero mas mababa yung number. The reason behind is that complete meaning complete absence of the ovum penetrated by one sperm, and then the sperm purely paternal duplicates. The P27 is a marker, a very specific marker for complete H-mole because this only comes from the paternal origin. And if you can see, this is worse than the other, right? So you have villous edema, very diffuse, and the uterine size is larger. This one is a common board exam question asked in pathology. What is the cyst associated with a complete H-mole? Answer, theca lutein cyst, not corpus luteum, not the primordial or follicular cysts, okay, but the theca lutein cyst. 25 to 30% associated with complete H-mole. And of course, you have more complications. You can even have GTN, gestational trophoblastic neoplasm, incomplete H-mole. I mean, higher propensity of developing into that. Okay, and the other way around, you have a 69. Why? You can have a 23 of ovum and then penetrated by 2 sperm. That's why you have 23, 23, 23. So opposite, okay? Partial H-mole, higher number than complete H-mole. This is purely paternal. This is combination. That's why you can still have some embryo development kasi nga meron kang from the mother and from the father. Okay, and then the villus edema is not worse. You have trophoblastic proliferation. The uterine size is not that big, and you still have complications that very at the lower rates. Okay, I hope it's clear. And HMO, we'll just review for OBGYN. You have abnormal vaginal bleeding at the first trimester, uterine enlargement, abnormally elevated beta HCG. Remember, guys, it's beta, it's not alpha, because the alpha subunit HCG is actually similar structurally with TSH, LH, and your FSH. Okay, you have theca lutein cyst, that's what I have mentioned. Why do you have hyperemesis gravidarum? Because a very high HCG, it like acts to relax your lower gastroesophageal sphincter. You can have preeclampsia with severe symptoms, and you have hyperthyroidism. Why do you have hyperthyroidism? Because as what I have said, the alpha subunit of HCG actually mimics a TSH. That's why you can have that as well. Okay, and the risk factors, masyadong matanda na si mami, or as what I have said, any history. Pag OBGYN, guys, any history of that same medical condition will predispose you to have that again. Okay, and what's the management? Suction, curettage. Okay, remove it. And then you have serial monitoring of the HCG post-evacuation, just to be sure that the levels are actually downtrending. Pag nag-plateau yan or pag nag-high, yeah, you have a high indication to screen for GTN or gestational trophoblastic neoplasm. And most of the time, they are advised to avoid contraception for 6 months to a year. Kasi hindi mo alam kung anong kayong HCG na nakikita mo in monitoring is coming from a pregnancy or is coming from a persistent trophoblastic disease. Okay? This time, ito na yung sinasabi ko sa inyo. Itong 3 germ layers, kailan nga ito na-form? Week 3. Okay? Gastrulation. Ectoderm. Saan nga yung ectoderm nanggagaling? Sa epiblast, right? Si mesoderm, nasa gitna lang yun. Sabi ni notochord dyan sa gilid. And then si endoderm, galing sa hypoblast. Nasa medyo ilalim. So, eto guys, ginawa ko to kasi litong-lito talaga ako before. I don't want to memorize each organ. And then from each organ, memorize ko, ito ba mesoderm, ito ba ectoderm. Hindi ganun mag-memorize. Ang gagawin nyo, master these 2 slides and you're done with embryology. Pagdating nyo sa each organ, boom, connect again back to the slide. You can memorize them on your own. Try to look at them now. I will give you some tips. And then from there, take it from there. So don't memorize by organ, but start with this. And then when you go to each organ, go back to this one. So it's easier for you. So general concept again, ectoderm, medyo ecto, medyo nasa labas. That's a general concept, but not an absolute concept. Okay, mesoderm medyo nasa gitna, endoderm medyo nasa loob. So mga hindi naka-highlight, yung mga naka-black lang dyan, those are common sense structures. I'll give you an example. Epidermis, hair and nails. Hindi mo na kailangan mag-isip. Pag nagsinagot mo pa ng endoderm, hindi ko na lang alam kung anong nasa isip mo. Okay? Teeth enamel. Kailangan mo mag-isipin yun. Lens of the eyes. Kailangan mo mag-isipin, nasa labas eh. Right? Anal canal below pectinate line. Remember? Below. Kasi above nun, endoderm na. Right? So, nasa labas. So, masyadong common sense. Okay? For this, because the ectoderm has 3 types, guys. Surface, neuroectoderm, and neural crest. Okay? Siya lang naman yung 3. The rest, isa-isa lang. Mesoderm, sinabi ko na to. Muscles, connective tissues, bone and cartilage. Okay? Medyo nasa gitna. Blood, lymph, cardiovascular organs, gonads, internal productive organs. Medyo nakakalito lang kasi pwede nasa loob din to eh. Okay? That's why pwede nyo siyang i-memorize. Endoderm, epithelial lining. Nasa loob mismo ng GI, lower respiratory system, GU, then the tonsils, parathyroid glands, and the thymus. Okay? The ones that I highlighted, ito yung mga nakakalito. Okay? Look at this, for example. Inner and external ear. Doc, bakit nasa labas? Tapos tingnan mo yung gitna, Doc, endoderm. Kaya nga hinighlight ko, hindi ko ma-explain eh. I-explain ko sa inyo, masyadong mahaba, pero memorize nyo na lang. Sobrang nasa labas at sobrang nasa loob, surface ectoderm. Ang nasa gitna, endoderm. Di ba hindi logical? Kaya kailangan nyo i-memorize. Okay? Pangalawa, anterior pituitary and posterior pituitary. Both of them are ectodermal in origin. However, specifically, okay, yung posterior is neuroectoderm. Kaya nga, nalala nyo anong other term ng posterior pituitary gland? Neurohypophysis. Correct. Okay? Kasi nanggagaling siya sa taas, dun sa hypothalamic area, pababa. Okay? Ang anterior pituitary gland coming from a surface ectoderm, galing yan sa parang oral cavity, na mag-meet sila, right? Halfway, the space in between is called the intermediate. Okay, so the anterior pituitary gland is surface ectoderm, but both of them are ectoderm. And then the posterior is coming from the neuroectoderm. That's a common board exam question, either in physiology, anatomy, or pathology. Okay? So makikita mo dyan, of course, mga pituicytes. Okay? Makikita mo dito more on, because the other term of anterior pituitary gland is adenohypophysis, right? Glandular, adeno. Posterior is more on neuroectoderm. So mas makikita mo dun mga nerve cells. Okay? Look at this again. Parotid gland. Surface, ectoderm. Ano yung mga kapareho niya? Submandibular and sublingual. Ayan na, nakakalito na, Doc. Pareho sila glands lahat, di ba? Salivary glands. If you still remember, sino dyan sa kanila yung purely serous? Ito lang naman, di ba? Si parotid gland. Submandibular and si sublingual, they are mixed glands, right? Meron lang predominance dyan, or hindi. Okay? Mucus is, sublingual is more on mucus, and mandibular is more on serous. So, memorize nyo na lang. Hindi ko alam paano siya i-organize sa brain. Okay? Look at this. Of course, this is CNS. That's neuroectoderm. Astrocytes and oligodendrocytes, these are your neuroglia, right? I hope you still remember the function of your astrocytes. So, and your oligodendrocytes. Oligodendrocytes is for the myelin sheath formation in your CNS, right? The astrocytes, ang daming function yan. Pwedeng barrier, pwedeng nutritional, pwedeng communication, ang daming function ni astrocytes. And then, look at this. Ano pang nakakalimutan nyo sa neuroglia? Meron kang microglia, right? You know what the other term or the older term of microglia in other books? It's mesoglia. Okay? Kasi nanggagaling siya sa mesoderm. Ito naman yung macrophage system ng brain natin. Okay? So pareho silang neuroglia, pero they come from different germ layer. So microglia or mesoglia comes from the mesoderm, and the two comes from the ectoderm. I hope hindi pa kina-overwhelm. Okay? And then, we have the next slide for the neural crest. Ito yung very magical layer in the development. Sobrang na-amaze ako sa neural crest kasi these are the cells that travel from one area to another, and then they differentiate. They either induce the resident cells in that area to differentiate, or they themselves will differentiate for that tissue. Okay? So look at this. Adrenal medulla versus adrenal cortex. Doc, bakit ang cortex nasa meso? Ang medulla nasa labas. Okay? Yan. That's why kailangan na i-memorize kasi naka-red siya. Right? The medulla is not in the mesoderm. M is not M. Okay? The cortex is the mesoderm. Ang cortex guys, hindi core ha. Ang cortex nasa labas. Ang medulla nasa gitna. If you still remember the adrenal glands. Right? Meron kang layers, diba? Glomerulosa, reticularis, diba? Meron pang, ano yung isa? Fasciculata, right? And then, yung gitna mo, andun yung mga blood vessels, kung saan na-form yung mga epinephrine and norepinephrine. Ito yung sa adrenal medulla, sa loob. Neural crest yan, guys. Mesoderm is yung cortex. About the layers of the meninges, medyo mahirap din. Yung dura, nasa mesoderm. Yung arachnoid and pia, nasa neural crest. Remember, the layers is DAP, dura, arachnoid, and pia. D, A, P. Yung D mo, nasa separate layer. Ang A and P is coming from a neural crest. Hirap, no? Parafollicular cells or the C cells is different from your follicles of the thyroid glands. Okay? So follicular cells of the thyroid is in the endoderm, parafollicular cells. Remember, this is what is mutated in your phaeochromocytoma, right? C cells, or sometimes in your medullary thyroid cancer, right? The C cells. Okay, and then you have this magical, I will just discuss them in a while, endocardial cushion, aorticopulmonary septum, ito yung nasa heart mo na very magical yung function nila. They come from the neural crest. And the melanocytes of your skin also come from your neural crest. And the Schwann cells, remember the Schwann cells gives you the myelin sheath in the peripheral nervous system compared to your oligodendrocytes, which gives you the myelin sheath in the central nervous system. What is the pathology, guys? Once you have a problem with oligodendrocytes in the central nervous system, you have a multiple sclerosis, right? What if you have problems with the Schwann cells? You have GBS, Guillain-Barré syndrome. Okay? And the spleen is part of your, sabihin mo na lang, hematopoietic organ para andun na siya sa mesoderm mo. Liver and pancreas, masyadong nasa loob. Okay? And those glands. Aram ko mahirap. Sobrang hirap nitong i-master. Pero I will just give you time to look at them, try to memorize them. Ngayon, at least meron kayong mapulot. At kahit pa paano, medyo kayong makorrelate sa brain nyo. Babalikan nyo ito mamaya. Or depende sa inyo kung kailan nyo siya gustong balikan. Okay? Importante lang, we have generalization in our brain. And let's try to see if we can answer questions related to that. Okay? I'll give you like siguro 15 seconds to look at them. Okay. Yan. Okay? Try natin sagutan to kung exercise lang, kung kaya nating sagutan yung information. I mean, i-apply yung info na ating nakuha. Okay? So, where do you think pancreas come from? Where does it come from? Pancreas comes from your endoderm, right? Okay. Hula-hula lang. Kidney. Medyo nasa gitna yun kasi genitourinary system. Mesoderm. Next one. Melanocytes. Okay. Nasa skin. Labas. Ectoderm. Pero ang tanong, is it surface ectoderm? Is it neuroectoderm? Or is it neural crest? Okay. If you still remember, it's the neural crest. How about the dura mater? DAP. The dura is different from A and P, the arachnoid and pia. Okay? The dura mater belongs to your mesoderm. How about the parotid gland, which is purely serous, parrot, pure parrot? It comes from your surface ectoderm. How about the auditory tube? That tube that's in between, not the extremes, that the outer or not the inner, because the outer and the inner comes from the surface ectoderm. The auditory tube is coming from your endoderm. How about the spleen, which is part of the hematopoietic organ in one way or another? That is where your mesoderm, okay, that is coming from the mesoderm. How about the adrenal cortex? Okay, saan si glomerulosa, fasciculata, and reticularis come from? Not the medulla. Okay, the medulla is where the epinephrine and norepinephrine are produced. That is your mesoderm. How about the endocardial cushion, the magical cushion in your heart that is in your neural crest cells? How about the oligodendrocytes responsible for myelin production in the CNS? Oligo, it's in the ectoderm, but is it surface? Is it neuroectoderm or is it neural crest? Okay, there's not microglia, but because microglia comes from mesoderm, the oligodendrocytes come from your neuroectoderm. How about the adeno hypothesis, which is the anterior pituitary gland? Okay, both the anterior and posterior comes from the ectoderm, but anterior comes from a different embryonic origin compared to your posterior. Posterior comes from neuroectoderm. Adeno comes from your surface ectoderm. How about your brachioradialis, which is a muscle, which is the easiest among the rest? This is your muscle in mesoderm, right? So if you memorize them one by one, this is very difficult, but once you just recall these slides with some exceptions, I hope they can help you with that, okay? Okay, how about answering that question? Let's see if we can answer that correctly. Parotid gland comes from surface ectoderm, pwede. Spleen is mesoderm, correct. Adrenal cortex is not, wait, neuroectoderm. Cortex comes from mesoderm. And middle ear, nasa gitna, it's coming from the endoderm. So the answer to that question is letter C. Good, good, good. Okay, so we're done with the embryonic origin. That's painful, but I hope you learned something. Are there any questions that you have for the first part before I go to the next part, which is easier? Easier. Any questions so far? Galing na mga mnemonics. Okay. So if there's none, then let's continue. Okay, this time epithelia and glands, easier to guys. So kayang-kaya na itong i-grasp kasi masyadong visual to. So hindi to ganun kahirap. Okay, pero recall lang natin yung mga basic concepts dito. Okay? And I'll start with a question. What is the epithelial subtype of a salivary gland ducts? I asked this question kasi this is one of the hardest tissues to memorize, like kung saan sila nanggagaling. Is it simple cuboidal, simple columnar, stratified cuboidal? Di ba nakakalito lahat? Siguro maalala nyo, ducts is different from a sinus. Okay, remember that the salivary gland is composed of a duct, and a sinus. Okay, okay. So what is the layer? What is the epithelial subtype of the duct? Okay, we will try to remember them, but the answer to that is stratified cuboidal. So simple, ano ibig sabihin ng simple? Elementary to guys, one layer. Stratified, multiple layers. Pseudo-stratified, they look like they are organized in multiple layers, but in reality there is only one layer. It's just that the nucleus or the nuclei are actually in different layers. That's why they look stratified, but in reality there's only one layer. Okay, and then the cuboidal, columnar, or squamous is named after the type of the cell that is on the top or at the bottom or at the middle. Okay, so because sometimes we forget, like how do we classify them? It's actually based on the architecture on the cells on top of the layer, especially if it's stratified. If it's simple, then alam mo naman kung ano lang doon on top of the cell. So if it's stratified, the topmost part, architecture of the cell, is the definition on the of this second term. So if it's stratified cuboidal, the top cell is actually more of cubes, like square-like pattern. or shape. Columnar is more of a longitudinal. And if it's flat, then it's squamous, right? So, basic. Ito lang, subtypes. Kahit ito lang, isipin nyo, magigets nyo na kasi marirecall nyo na to. Simple cuboidal, one layer, and then cube-like in shape. You have the renal tubules. If you remember your PCT and DCT, I will show you later. And then the salivary gland acini. Okay, that's what I've said. The duct and the acini, those acini is actually simple cuboidal. Okay, one layer and then cube-like shape. Simple columnar. Columnar is actually for absorption most of the time. So you see that in the small intestine, right? The enterocytes. Simple squamous, very thin-like structure, most likely for exchange of gases or fluids. Okay, so you have the endothelium, which is lining your vessel. Mesothelium, lining some of your organs with a membrane, serous membrane, and Bowman's capsule. You have this in your kidneys, right? Stratified, you have different multiple layers, and then the topmost structure is flat. You see that in the esophagus, okay, and the skin, or even in the vagina, right? What makes esophagus non-keratinizing, and what makes the skin keratinizing? I asked one student, and he said the presence of keratin. It makes sense, but it doesn't actually. It's not the actual explanation for that. When you say keratinizing and non-keratinizing, it's actually the absence or the presence of the nuclei. If it's keratinizing, then that's non-nucleated kasi namatay na sila. That's why you have a keratin, right? Non-keratinizing, or the wet type, you still have the nucleus of the cells. Okay, so esophagus and the vagina, you have non-keratinizing, nucleated, topmost cell. Skin has keratinizing, non-nucleated. Okay, the pseudostratified columnar, ito yung pinakasikat sa exam natin anatomy before, right? Pseudostratified, ciliated columnar cells with goblet cells, or the respiratory epithelium. We see that in the trachea and then the epididymis. Okay, you also have a special structure in the epididymis that looks like a cilia, like stereocilia, yung sobrang gandang structure doon, yung nalala nyo yung slides natin. Then transitional. So it depends on the degree of the distension of the organ. If it's too distended, then it actually thins out. If it's not filled with any fluid, then it becomes 5 to 7 layers. Okay, that's you see that in the ureter and the bladder. These are very distensible organs, and they're compliant. Okay? It depends on the amount of fluid that they have to hold. And then the first question that I showed you, the salivary gland ducts, stratified cuboidal. Okay, look at this. So this is one layer, right? Simple. And you look at the shape of the cell. This is cuboidal. Okay, do you remember what organ is this? Actually, the kidneys, right? So this is the PCT, and then this is actually the DCT. If you still remember, you have a brush border, right, in the PCT. So dirty siya, pinkish pa yan, and more square-like than rectangular. And if you can see, DCT is cleaner, the lumen, than your PCT. So this is a simple cuboidal, just to remind you. Okay, and that's why you have more absorption here than the DCT, right? Because of the presence of this brush border. How about this one? This is one layer, right? And you have a columnar cell, okay, in column. This is actually the enterocyte in your small intestine. You have this unipolar cell, the goblet cell, right? And you have this basement membrane and then the lamina propria. And then you have some thin-like structures there, maybe the microvilli, right? That increases the surface area for absorption. Okay, so you have the plicae circularis, those folds that you see macroscopically. And then you have the villi that increases like 10 times absorption, 3 times the plicae circularis, or the volvuli conniventis, right? If you still remember, it increases the surface area by 3 times, the villi by 10 times, and then the microvilli by 30 times. 3 times 10 is 30. Okay. I just want to remind you, okay, this is your PCT, right? We have simple cuboidal, we have dirty lumen. These are your PCT, and this is the Bowman's capsule. If you can see, this is a simple, squamous epithelium, flattened, right? And this is the Bowman space, right? And this is the glomerulus. Okay. How about this one? You have the basement membrane here, okay? And then you have here the cilia, okay? And this is, looks like different layers, one layer, simple. It looks like multiple, right? Multiple layers, but if you trace one cell like this one, from the bottom to top, you only have one nucleus, okay? So from bottom to top, you only have one nucleus. It's just like the arrangement of the nucleus is actually, looks like stratified, but this is only a single layer. That's why this is a pseudo stratified columnar epithelium with cilia. So this is a classic presentation with goblet cells. Classic presentation of trachea, right? If it's stereocilia, then this is an epididymis, but this is a trachea. This is more in the respiratory tract system. And what are these cells called? It looks like an umbrella. This is the transitional epithelium, right? It depends on the amount of distension that the organ has to be in to accommodate the volume of fluids. So this is your transitional epithelium in the urinary bladder. Okay. And if you can see, this is your not this one, mali yung arrow. This is the stratified cuboidal epithelium. This is actually your salivary gland ducts. Okay, you have different layers, like 1, 2 layers, and then the topmost is more like a cube-like structure. Okay, these ones are flattened, more on the blood vessels. Okay, and if you can see, this is a glandular structure. Okay, so you have serous type and then the mucus type, right? If you still remember, this is not purely serous. This is a submandibular versus sublingual. If you still remember what is predominant in sublingual and what is predominant in submandibular. So this is more of serous than mucus. Okay, the pale structures there is more mucin accumulation. So this is more of a submandibular organ. If the predominant type is mucose type, then that is your sublingual. Okay, and if you can see, I don't know if you still remember this one, the serous cell capping your mucose cells. Okay, this is a clue that you're looking at the mixed type of gland by type of secretion. This is your serous demiluns, right? Serous demiluns. Okay, so this is a mixed gland. This is not parotid, but since the predominant type of cell is serous, then this is submandibular. Okay, if the predominant type is mucus, then you have sublingual. Okay. Now we have a different layers of the skin right now. This is first layer. I hope you still remember the stratum basale, right? Or the stratum germinativum. Then the second layer is the thickest layer, the stratum spinosum. This is the spiny layer. The third layer has this granules, keratohyalin granules, so call it stratum granulosum. Okay. And the fourth layer from bottom to top, ito yung hindi consistent kasi minsan in thin layered skin, you don't have this one. That's why it's lucid, stratum lucidum. And then the last layer, the topmost, which does not possess any layer, that doesn't possess any cells, non-nucleated, that's what's keratinizing. That's the stratum corneum. Okay, so ulitin ko, stratum corneum, stratum lucidum, which is not consistent in all types of skin, stratum granulosum, you have the granules, stratum spinosum, which is the thickest, and the bottom part is the stratum basale, or the stratum germinativum. Okay. Question. Which of the following skin layers houses the tonofibrils? Wait, hindi ko to alam. Corneum, maybe nasa taas lang. Lucidum, I would actually eliminate letter B because This is more on, this is not consistent, so hindi siya pwedeng maging answer to this question. If I were to choose, I would choose a layer that has the thickest, that is the thickest, and probably could house a ton of fibrils. So by just looking at this structure, I would guess maybe the spinosum has it. Yeah, okay. So stratum spinosum houses your ton of fibrils. So this is just a summary of the layers and what you see. So just so you remember the things that matagal na nating pinag-aralan. Okay. So look at this. The first structure, the stratum basale, which should shed every 15 to 30 days, has melanocytes. Okay, saan to nanggagaling ang melanocytes? Anong embryonic origin? Neural crest, correct? Keratinocytes. So most of the stem cells actually would come from the basale. Kaya germinativum siya. Ay doon nanggagaling. You have desmosome and hemidesmosomes. We will discuss this in detail in a few minutes para mas ma-correlate nyo sa brain nyo kung ano tong functions nila. So dapat every 15 to 30 days sila nag-shed off, right? But in case of psoriasis, ito yung mas frequent shedding. Less than a week, nag-shed sila. That's why the dysfunctional layer in psoriatic patient is the stratum basale. Okay, the next layer, which is the thickest, houses your ton of fibrils and also has desmosome. So this is the question. And once the ton of fibrils produce granules, granulosome, right? And then only the thinnest layer is the lucidum, which is absent in some thin layered skin. Yung mga maninipis yung mukha, medyo wala silang lucidum. Yung makakapalang mukha, makapal din to. Desmosome, yan. And then the only structure present is desmosome, and the stratum corneum is the topmost layer. 50 to 20 layers of non-nucleated, kaya tinatawag silang keratinized, full of keratin, and then no nucleus at all. They're dead. Dead cells. So if you can notice, the desmosome is constant from basale layer up to lucidum layer. So we can derive a concept that desmosome could be like a structure that binds cells side to side from bottom to top, except for the corneum. And we will see that later. And ano yung function nila, ano yung pathology that is implicated once the desmosome is affected or once the hemidesmosome is affected. Look at this. The hemidesmosome is only found in the basal layer. So you can imagine that if I am standing on the floor, hemidesmosome is right under my foot. Okay, the desmosome, if I have someone beside me, connecting me to that person, side to side. Okay, but for me, connecting to the floor is actually the hemidesmosome, and that makes sense, right? Stratum basale, andun lang yung hemidesmosomes, and then the desmosomes from layer 1 hanggang layer 4. Okay. Yeah, so we have cytoskeletal elements. Minsan inisip natin, useless to mga ganyan, pero alam mo, sobrang helpful nila pag naiintindihan nyo. In pathology, most especially anatomy questions. So we have 3 different cytoskeletal elements, okay? So we have, by size, ang microfilaments is the smallest, hanggang palaki ng palaki, intermediate, and then microtubules. Although micro and micro silang dalawa, but the largest of these 3 is the microtubules. The smallest by size is the microfilaments. Look at the action. So microfilaments undergo continuous assembly and disassembly. This is very important. I will show you why. Involved in cell contraction and motility, involved in tight junctions, and at zonular adherence. Ito yung mga terms na minsan hindi mo na maalala. Ano nga yung zonular adherence, occludence, diba? Macular adherence. We will try to recall that in a few minutes, okay? There's one thing that I would want you to remember about microfilament. Think about microvilli. They form the core of a microvilli. And you know where microvilli is located? In any site where absorption is high, and any site where absorption is needed, microvilli should be present, right? Because as what I have said, microvilli increases the surface area by 30 times, villi by 10 times. Okay, in the intestine, the plicae, the folds that you see, only 3 times. Okay, so microfilament, microvilli. Associate them all the time. Okay, for the intermediate filaments, they are structurally stable. Hindi sila nag-undergo ng assembly or disassembly. Unlike the the microtubules, both of these undergo assembly and disassembly. Itong intermediate filaments mo, they are stable. Okay, so we have a type 1, keratin. Okay, in the skin, keratinocytes in basal layer, keratin in the stratum corneum. They are intermediate filaments. Type 2, you can have desmin for the muscle and vimentin for non-muscle. GFAP, which is the glial fibrillary acidic protein, and peripherin. Type 3 is neurofilaments and type 4 lamin. Doc, ano yan? Hindi ko maintindihan bakit may ganyan. What is the essence? What is the importance? Look at this. In pathology, if you have a question and then they say that the desmin is elevated, then you know that you're dealing with a muscle pathology. For example, sinabi nila, ugly looking cells, na merong positive desmin, you know that you are dealing with a rhabdomyosarcoma, right? Pero pag sinabi nilang vimentin is positive, desmin is negative, then you are sure that you're dealing with a non-muscle pathology. In the case of fibroma, desmin is negative, vimentin is positive. In the case of astrocytoma, GFAP is increased, right? The glial fibrillary acidic protein. So these are very important concepts in pathology. Okay, keratin, as what I have said, in the layers of the skin. Neurofilaments is very important in case of when they ask about Alzheimer's disease. Remember, you have senile plaques, right? You have neurofibrillary tangles, and they involve neurofilaments. So if they ask an Alzheimer's disease patient what kind of cytoskeletal element is actually defective, then you answer intermediate filament, right? And in the microtubule, so those are the things that you have to remember in intermediate filaments. And sometimes, you know, you have alcohol liver disease. You remember that pinkish body that you see? That's the Mallory body, right? They're also intermediate filaments. They can ask that in pathology. So what they do is they present you with a case, alcoholic patient coming in with elevated liver enzymes, and then they showed you, they will show you, I mean, they will describe the pinkish structure, hyaline bodies, and they will ask what is the cytoskeletal element involved. So you are to choose between microfilament, intermediate, and microtubule. Okay, so that's intermediate, or even Alzheimer's disease. Okay, that is what is the importance of this slide. In microtubules, very important. So if microfilament is for microvilli, microtubule is for cilia and flagella. Okay, you have dynean arms there. I will show you later the structure of the microtubule. You have 9 pairs outside and 1 single couplet in the middle. The classic microtubule, that is the core structure of your cilia and flagella. Okay, and then they're involved in transport of vesicles. So dynean and the kinesin arms, just remember the dynean is responsible for retrograde transport of vesicles. The kinesin is for anterograde transport. I usually interchange them. So ang ginagawa ko, I just memorized them as Dr. Khan, D-R-K-A-N. So Dr. Khan is for microtubules with the cilia and the flagella. Okay, so microfilament, microvilli, intermediate filaments, the types that I have mentioned, and the microtubules, cilia, and flagella. So those are the main things that I would want you to remember about them because they can be asked. All right, so let's start with the microfilament, microvilli. I've already told you they increased absorption by 30 times. We will discuss this later, the desmosomes, the zonula adherens, the zonula occludens. Okay, just remember their structure. So, alala nyo, yung kanilang ano, they bind cell side to side, okay? And then the desmosome, actually several layers. And then you have the microvilli here, that is coming from your microfilament. Okay, so they can ask you in the intestine, or sabihin nila, like in patients with lactose intolerance, since the microvilli is actually affected post-viral infection. So nagkaroon ka ng problem with absorption, with what structure cytoskeletal element is affected. So that's microfilament because it's talking about the microvilli. Okay. So what I have said, changes in intermediate filaments are evident in neurons in Alzheimer's disease and in chronic liver disease. Sometimes nga meron ng kahit nga biliary cirrhosis, even in fatty alcohol, non-alcoholic steatohepatitis, you can still have Mallory bodies. So both of these are coming from your intermediate filaments. Okay. Look at this, the cilia. So, ano sabi ko kanina, microfilament to microvilli, microtubule to cilia. So this is your microtubule, more on the transport, mitotic spindles, all those types. So you have here the structure, if you can see, cross-sectional view. You have one couplet in the middle, and 1, 2, 3, 4, 5, 6, 7, 8, 9 couplets surrounding. Okay? So ito yung mga dynein arms natin. Sino nga dito yung retrograde and anterograde? So doctor, DR, D is for dynein, R is for retrograde. And then I don't have the kinesin here, not much pathology involved, but more on the dynein arms. Once the dynein arms are affected, you also have a malfunctioning microtubule, okay? And then eventually a malfunctioning cilia. So you expect what happens in patients with ciliary dysfunction, immotile cilia syndrome, right? Okay, so let's talk about pharmacology that affects microtubules. Okay, remember at the first slide that I showed you about cytoskeletal elements, the function of these cytoskeletal elements. For the microtubule, they assemble and disassemble, right? They're continuous, very dynamic, just like your microfilaments. So there's this one drug that prevents microtubule assembly. So remember, before the microtubules are fully functional, they have to undergo assembly and disassembly. Now, once the microtubule assembly is inhibited, then it cannot proceed to a disassembly state, and therefore it becomes dysfunctional. What is that drug that will prevent microtubule assembly and prevents neutrophil migration in gout? That you give in acute state, or sometimes in prophylaxis, very, very occasionally, that has a side effect of diarrhea. Okay, that is your colchicine, right? Now, colchicine is not only for gout, they can even be used in patients with recurrent pericarditis, right? And also they can be used in patients now with ACS, heart failure. That's the newest application of colchicine, but still under research. But they have seen a very specific receptor for this one that helps with heart failure with reduced ejection fraction without giving much adverse effect. So, but primarily for gout, that's the action, preventing microtubule assembly and neutrophil migration. How about this second drug that inhibits another assembly of a mitotic spindle that are used in chemotherapy? So dalawa tong drugs, guys, that involves microtubules. One is for assembly, one is for disassembly, right? In the process. These are both chemotherapy. So this first drug actually are vinca alkaloids, okay? And just remember, it prevents assembly. V, I will assemble U before the taxane, the X, disassemble, okay? So V is for assembly, X is for disassembly. It will inhibit those function. So vinblastine, I don't know if you still remember the most common side effect in pharmacology, that is your bone marrow suppression, right? And vincristine, that's more on your neurotoxicity. So you have like peripheral neuropathy in vincristine. Vinblastine is for bone marrow. Okay, so inhibiting your disassembly is your taxanes. Okay, your cisplatin, all those platines that you know. Okay, and how about this medication that binds to alpha and beta tubulin, that is the drug of choice for your tinea capitis? Okay, if you still remember your grisufulvin, that involves your microtubules. That's why this cytoskeletal element is not to be disregarded. And How about another medication that is antihelminthic and binds to your beta tubulin, preventing assembly into microtubules? Very common use in the Philippines. That's your albendazole and mebendazole. Albendazole, you can give it once, mebendazole 3 times a day. Okay, so these are the drugs, only the drugs that affects your microtubules. That is a clinical correlate to your pharmacology from histology. Okay, remember this, 2 chemotherapy, guys, they're commonly asked. And even the face of the mitotic spindle the face of mitotic spindle formation is asked. Nakakalito lang kung sino yung inhibiting assembly and inhibiting disassembly. Another correlation for microtubule, as what I have said, the core of the microtubule is cilia, right? Sorry, the core of the cilia is microtubule. So once microtubule is malfunction, then the ciliary function is also affected. Okay, so this is Cartaginer syndrome, which is another term for immotile cilia syndrome, right? So we have a triad of this. You have bronchiectasis. What is bronchiectasis? This is an irreversible dilatation of the airway from a recurrent infection. So you just imagine a pseudostratified columnar epithelium without any cilia. So any toxins, any smoke, any foreign particles could go inside without the ciliary motion expelling those foreign particles. So at risk of recurrent infection, that's why you have bronchiectasis in Cartaginer syndrome. You also have a chronic rhinosinusitis. You still have cilia in the upper respiratory tract. And remember that microtubules in the development also not only is responsible for forming your cilia, but they're also responsible in moving organs all around. Okay, so that's why you have a situs inversus with dextrocardia. So the heart is not located on the left side, but on the right side. Okay, and very few, some men actually have infertility from also stereocilia affectation. Okay, but a triad, this is the triad for microtubule problem affecting your cilia. Okay, I hope so far everything is clear. Hindi pa tayo nagkakagulo. Okay. So the next, this slide is talking about your cell adhesion molecules. Okay, basic concepts that we have to remember. Wait lang, give me a second. Slideshow. So you have here cadherin, you have their selectins, and you have there the integrins. Okay, some of you medyo nakalimutan na to, pero let's just try to study again. Okay. So cadherin, these are both cadherin and selectin are calcium ion dependent. Itong integrins na to, very very interesting to siya. Independent of calcium, I can function on my own. Just remember, guys, the receptors for each. Cadherin to cadherin. Okay, very important to guys in preventing metastasis in cancer. Kasi sila yung nag-prevent ng metastatic cells to actually spread to other organs. Okay, cadherin to cadherin, they are calcium dependent. And then the selectin is also calcium ion dependent, and they have to bind to a glycoproteins. Okay, remember the receptors. The integrins, very choosy, they want immunoglobulin family. Okay, and the interaction between the integrins and these adhesion molecules are very strong, and most of the time permanent. Okay, unlike the cadherin and the selectins. Okay, so look at this. This is a slide from pathology. I just put this so you can associate the previous slide with this one. So as you can see, you have here a glycoprotein, and that's what we have mentioned, that glycoprotein will choose selectin. Okay, so this is a neutrophil or a leukocyte in the middle of the blood's vascular component without any site of infection, without any need. The leukocyte will just have to be in the middle. No need to actually transmigrate without any site of infection, without any need or necessity to do that. So Itong mga glycoproteins nyo guys, they will look for selectins, right? Glycoprotein, selectin. So this selectin could be like platelet selectin, you have endothelial selectin. These are expressed once you have cytokines from the phagocytosed microbes. Okay, so after phagocytosis, they release this DNF, tumor necrosis factor, and IL-1, and they will have, this will induce the expression of your selectin on the blood vascular wall. And this will signal also your leukocyte to actually go there and bind. So sa lab story to guys, ito yung parang rolling lang, yung walang seryosong intention. Wala lang, kita tayo, tapos roll ka na naman sa iba, dun ka sa iba. Not committed. Okay? So yung mga selectin dyan, hindi yan sineseryoso. Okay? So selectin to glycoproteins. Okay? So they start rolling and rolling. And then, once the chemokines are also produced from this phagocytosed macrophages, they will induce the formation of this integrin ligand, and also at the same time will change the low affinity integrin to high affinity state. So from like titingnan niyo dyan, yung structure niya naka-close, this one straightened up, and they're ready to actually bind to an integrin ligand, most of the time like immunoglobulin family. So ICAM stands for intracellular adhesion molecules. Sometimes they look for VCAM or vascular cell adhesion molecules. And this time, the integrins, hindi to kagaya ng mga selectin guys na parol-roll lang. Yung mga walang seryoso, walang intention, walang label. Ganun. Ito mga integrins, hindi, seryoso to sila. So once you bind with them, they have the cell will have a stable adhesion. So look at this. The integrin ligand will bind to your integrins and will allow these neutrophils to actually adhere to the wall in a stable manner. Okay, so once they are adhered on this integrin ligand, then this PECAM1 or CD31, this is a commonly asked question na hindi alam ng nakakarami, will induce the transmigration. Look at this, will induce the transmigration of the neutrophils that have already attached to the blood vessel wall, and then they will go to the site of where the microbes are. Alam nila kung saan pupunta because the chemokines or cytokines are to begin with produced by these cells that have phagocytized the macrophages. Okay, so things to remember: glycoprotein, selectin, integrin to your integrin ligand, more stable than the glycoprotein selectin interaction. Okay, so I hope you remember this one: selectin to glycoprotein, integrin to adhesion molecules, specifically the immunoglobulin family. Why is this important? Okay, we have different pathology associated with that. Just to recall and review, P stands for platelet, E stands for endothelium. Sometimes you have L, lymphocyte. So these selectins actually will bind to your glycoproteins, that's your sialyl Lewis X, for rolling and adhesion. This adhesion is not very stable. Okay. The integrins will bind to your ligands, the immunoglobulin family. Very specific molecules in the integrins. This is important because we have a specific pathology for this. CD11 and CD18 integrins bind to your ICAM. Look at this: firm adhesion, arrest, and transmigration. And the CD31 is solely responsible for transmigration of leukocytes. This can be asked in the pathology questions. Okay, that's why I included that one for the benefit of the board reviews. So we have a clinical correlate. You have these two pathology in newborn, in pediatrics. Leukocyte adhesion deficiency 1, which is a mutated CD11 and CD18 integrins, which is more common. Okay, and what do you think is more severe? Which pathology, the 1 or the 2? Look at the mutated structure. What is mutated here is the integrins. What is mutated in type 2 is only the sialyl Lewis X glycoproteins. And remember, these glycoproteins, rolling lang yan, di ba? Walang commitment. Kapag nawala sila, ayos lang, right? hindi masyadong masakit. Hindi ko alam, depende sa inyo. Pero, yun, kapag ang nawala is integrins, ito talagang pinanghawakan mo, sure ka na ikakasal na kayo, tapos iiwan ka, masakit to. Kaya more severe presentation because you don't have any ability for the neutrophils to actually transmigrate and go to the site of infection to phagocytose more microbes, right? So this is more common, the type 1. This is more severe in presentation. And look at our presentation for both. Only severity differs, right? And the pathology. Remember these ones. They can be asked in pedia. They can be asked in pathology as well. You have a problem with recurrent bacterial infection. Bakit? Kasi nga, the neutrophils in type 2 cannot do the rolling. In type 1, it cannot even adhere. And remember, stable adhesion is a prerequisite before transmigration, right? That's why you have a recurrent bacterial infection. And as a consequence to that, you have a delayed umbilical cord sloughing, delayed healing. Remember that neutrophils are important in healing. Omphalitis, okay, you have inflammation of your umbilical cord and inability to form pus. Why? Why can't you form pus? Kasi nga, the neutrophils cannot eat up your microbes. Wala kang pus formation doon, wala kang debris, right? And Doc, bakit may neutrophilia? Kasi nga, hindi makapunta sa site. Saan lang sila? They stay in the vascular compartment. That's why WBCs are very high, but they cannot form pus. So that's the clinical presentation. Sorry, mas pala yung clinical ko. There's a clinical presentation of a patient, of a pediatric patient with leukocyte adhesion deficiency, inability to form pus, and a very high neutrophilia. And the clue there, delayed umbilical cord sloughing. Like after 2 weeks, hindi pa rin nagsaslough yung umbilical cord. Okay? I hope that's clear. Okay, as what I have said, a first step in the invasion of malignant cells through the epithelium results from loss of expression of cadherins. Remember, cadherin to cadherin. Okay, this interaction should be weakened by the malignant cells in order to cause in order to cause metastasis. Okay, there are 2 carcinomas that with the loss of E-cadherin. Actually, there are a lot of carcinomas, but these are the most common that are most commonly asked. Okay, so one clue that I have for you, I know you know some of them. This is a breast cancer type that is more multifocal than unifocal, multicentric. And in pathology, they would give you an Indian filing pattern, lobular in component. That's why it's a lobular carcinoma of the breast. So if they ask you what's the mutation commonly involved in that, the answer is E-cadherin mutation. So the E-cadherin expression of that gene is actually inhibited. So you have less cadherins, you have less gate to prevent the metastasis of malignant cells. And the second one, it's another carcinoma of the glands that presents usually with a linitis plastica, if you still remember, like a leather bottle sign in the stomach. That's your gastric adenocarcinoma. That you have signet cell ring adenocarcinoma. That's your gastric glandular carcinoma. So these are the 2 most common. Although meron ka pang prostate, although meron kang colorectal CA that would present that way. Pero when it comes to the 2, I mean, when they ask about lobular and gastric adenocarcinoma and they ask about the mutation, the answer to that is your E-cadherin mutation or loss of expression. That's why you have early metastasis in these types of cell. Gastric adenocarcinoma, most of the time, these people do not actually survive. Very common among the Japanese population, right? And lobular carcinoma, although ductal is more common than lobular, just expect that more metastasis is involved in this over the other. Now we have a cell surface specializations. Let me see before we have a break. Yeah. Okay. So we have, I don't know if you still remember the microvilli picture with the zonula adherens, zonula occludens. So this is a time to review some of them kasi minsan nakalimutan na natin to. Diba? We have occluding junctions that forms like a belt-like structure around the cell that maintains the polarity of the cells. That is very important kasi the apical structure should remain apical, the basolateral should remain basolateral. So it maintains the polarity. That's actually the belt-like shape forming seal around the epithelial layer. So the other term for that tight junction, if you don't find that, some board examiners will use zonula occludens because it will occlude. It's actually an occluding junction. And most of the proteins involved is the claudin and junctional adhesion molecules are occluded. And another below the zonal occludens or below the occluding junction, I just want to show you a picture so you have an idea of what I'm talking about. So this is a tight junction, okay? The belt-like structure attaching the apical to the basal layer. This is the occluding junction, the tight junction, or the zonula occludens. The zonula adherens is actually located just below that one. And then you have the desmosomes connecting cells side to side. And then you have the basal lamina here. So you just have an overview of what I'm talking about. And you have the gap junction here. It's called gap junction because in between the two cells, you have gap that you can see between cell C and cell D, right? So this is a gap junction. This is a desmosome. There's no gap in between those two cells, okay? So tight junction, zonula adherens, or the anchoring junctions. You also have desmosomes here and the gap junctions, okay? Para maalala nyo. So let's go back. Occluding junctions are also called tight junctions or zonula occludens, okay? So alam nyo na yung function nila. Adhesive or anchoring junctions, we have two types, okay? I mean, two cells that play a role as adhesive junction. You have zonula adherens and you have the macula adherens. Remember, guys, the desmosomes' other term is macula adherens, okay? This is different from zonula adherens, but both of these are adhesive or anchoring junctions. Ang apelyido kasi nila adherents, so they're adhering junctions. Apelyido nito is occludens, so this is occluding junction. Okay? Pero magkaiba sila. Zonula adherens is just below the occluding junction, or the zonula occludens, and the desmosome connects between one cell to the other without any gaps in between. Okay? Unlike your gap or communicating junction, okay, you have here very important function because it actually causes one certain organ to act in unison, like the heart structure or smooth muscles of the vascular vessel wall, so that they act as one. So we have to transmit the conduction or the message very quickly using this gap junction so that they can contract as one. And then the other cell surface specialization is your hemidesmosome, which will bind the cells to basal lamina. So this is your hemidesmosome there. Okay, it will bind the cell to the basal lamina. Okay, side to side is desmosome, cell to bottom is hemidesmosome. Remember that because different pathologies involving hemidesmosome and desmosome will give you different pictures. And once you remember this one, kaya pala ganito. It's important to remember them. Okay, and the basal lamina is actually part of the basement membrane. So the basement membrane is composed of two structures, the basal lamina and the reticular lamina, reticular layer. The reticular layer is more of a type 3, collagen. The basal lamina is type 4, the laminin, okay? And between this type 3 and type 4, actually type 7 will connect these 3 and 4. So reticulin and basal lamina is connected with the type 7. So para hindi mo makalimutan yon, reticulin is type 3, lamina is type 4, 3 plus 4 is 7. So type 7 connects 3 and 4. Why I'm telling you this? Because there is a pathology that actually targets the type 7 collagen, and that essentially will break the connection between the basal lamina and the reticulin fibers. If somebody knows about this, The pathology is the epidermolysis bullosa. Yung sobrang mabilis lang sila mag bullous formation, even with very photosensitive. So that is the pathology behind it. They attack the type 7 collagen, and that type 7's function is to connect reticulin from the basal to the basal lamina. Okay, so remember the desmosomes, remember the hemidesmosomes, okay, because we have different pathologies involving that. Okay, so this is commonly asked in IM, dermatology, or this can also be asked in pathology, clinical correlates of what we have just talked about. So remember that one. So you remember the pemphigus vulgaris, okay? This pemphigus vulgaris is intraepidermal, okay, in origin. The blisters are actually intraepidermal. So the pemphigus vulgaris actually attacks your your desmosomes, or the desmoglian 3 is actually defective. And if you can still recall, the desmosome connects one cell to the other. So pag yan affected, then these cells will actually disintegrate. Remember, the basal lamina is not affected. We are only talking about the intraepidermal layer. Okay, so if you can see this one, what kind of bulla do you expect in this intraepidermal blister where the desmosomes are actually affected? So this interaction between one cell to another is affected as well. So the intraepidermal blister will give you a flaccid or a tense bulla. So if looking at this is an intraepidermal layer. The basement membrane is intact, pero sobrang nasa taas siya. And logically speaking, titingnan mo siya as it will give you a clinical presentation of a flaccid bulla. That's why you have a positive Nikolsky sign there. If you still remember, pag ginanon mo ng pencil, di ba, madali siyang ma-disintegrate. Right? This is an autoimmune disorder involving IgG attacking your desmoglian or desmosome. That's why the cells are disintegrated. Okay, you have acanthocytes there. And if you stain this one, you have a net-like pattern, staining. Kasi nga, paiba-ibang layer, pwede dyan siya na-disintegrate, dito, okay? Or pwede sa baba, but not the basal lamina, because the hemidesmosome in this case is still intact, right? So, pemphigus vulgaris is autoimmune, IgG attacking your hemidesmosomes. You have a flaccid bulla, you have a positive Nikolsky sign. And what's the management? Since it's autoimmune, then you have to inhibit inflammation. So you have to give steroids, right? So ito yung nagpa-positive ka ng Nikolsky sign. How about the subepidermal? So iisipin mo, ilalim na to, right? Look at this. They're intact. The desmosomes are intact in bullous pemphigoid. But the problem with the bullous pemphigoid is that the hemidesmosomes here are affected. So if you can still remember, the hemidesmosomes connects the cell to the basal lamina. So pag ito nawala, okay, you have a disintegration underneath each cell. That's why you have a clean space between the basal lamina, in the bottom layer, and the basal lamina. So what do you expect? What kind of bulla do you expect? Intact yung baba. This is a very, very tense bulla, and you don't get any Nikolsky sign in there. Okay, so negative Nikolsky sign, subepidermal, kasi ilalim siya, because what is affected is desmosome. And your clue here is you have eosinophilic infiltration in pathology. Okay, that's unique in bullous pemphigoid. And once you stain this one, you have a linear pattern. Okay, you have a linear staining because the hemidesmosomes are actually separated in a uniform manner from the basal lamina. The bottom lowermost layer is actually disintegrated from the basal lamina. So you have a linear staining. This one you have a net-like staining pattern. You have another subepidermal blister. You call it dermatitis herpetiformis. The structural affectation is almost similar with bullous pemphigoid, although the because the bullous pemphigoid is also autoimmune. Like this one, it's autoimmune. So IgG attacking the hemidesmosomes. This one, although it doesn't attack the hemidesmosome, they are IgG attacking your gliadin or transglutaminase, because this is more associated with your celiac disease, right? Or yeah, celiac disease or celiac sprue. So what is differentiating between bullous pemphigoid and dermatitis herpetiformis is the presence of this neutrophils. Yeah, and who's writing? It's already neutrophils versus the eosinophils. Okay, so the presentation is almost the same. You have a negative Nikolsky sign. Why do you have a negative Nikolsky sign? Because the blister is located under, okay, the epidermis. It's a dense bulla as well, but instead of IgG attacking hemidesmosomes, you have IgA attacking your gliadin or transglutaminase. And the differentiating factor in pathology is neutrophils versus eosinophils. Okay, that's why we're taking the pathology boards. And then the last one of the subepidermal blister type is your PCT, or Porphyria cutanea tarda, which is actually enzymatic problem, heme synthesis, pathway that is affected, not any autoimmune disease, not unlike this too, which is autoimmune, you can give steroids. This one, you just have to avoid, right? Some food that would induce celiac sprue exacerbation. This one is more of a heme synthesis pathway affectation. The presentation is almost similar. No Nikolsky sign, tense bulla, subepidermal blister, and you don't have any inflammation here because this is not autoimmune, this is not inflammatory, this is more of an enzymatic pathway affectation. Okay, very clean. Okay, and then you have neutrophils in dermatitis herpetiformis. That's why in pathology questions they can give you granular staining with micro abscesses. Okay, that's neutrophils. Abscesses is from the neutrophils. That is pointing to dermatitis herpetiformis than bullous pemphigoid, because they can present similarly. Okay, what is unique about PCT, since it's not autoimmune, no inflammatory cells involved, they're very clean. Okay, because the disorder is more on the heme synthesis than on any antibodies that are involved in these three other pathologies. Okay, so in summary, if you just remember this one and this one, okay, these structures, desmosome, hemidesmosomes, and this slide, we can summarize these four dermal, dermatology conditions into this one table. This is very important. They can ask you that. They can also ask, this can be asked in pathology as well. So remember that. So the only intraepidermal is the pemphigus vulgaris is worse than this one. And as what I've said, it's flaccid because it's above the lowermost layer, and it's intraepidermal. It's autoimmune, so have an IgG, and the pattern is net-like, okay, because you don't have a specific one layer affected. And what is affected is your desmosome. This is very important to know, okay. And the management, since this is autoimmune, you can give steroids. Bullous pemphigoid, this is, negative Nikolsky sign. Yeah, the bulla is tense because it's subepidermally located. This is autoimmune, IgG mediated. That's why steroids can also work. And then you have a linear pattern. That's what we have seen, right? Very linear. And involved is your hemidesmosomes. The cell to the bottom part of the to the basal lamina attachment is the problem. Dermatitis herpetiformis. Actually, you see this itchy, at the back of the buttocks or maybe at the extensor areas. These are the common site in celiac disease patients. And then you have these micro abscesses, and then you have a celiac sprue setting. And then the autoimmune, the antibody involved is your IgA. And the management is just avoidance of some specific food. And the last one is your PCT, similar presentation, All of these have negative Nikolsky sign. Okay, so the only one with positive is the pemphigus vulgaris. And then you have minimal inflammation to no inflammation. The dermal vessels are thickened, and the disorder is on your heme synthesis than any autoimmune pattern. Okay, so this one is kind of medyo magulo, medyo mahirap alalahanin, but I'm just presenting this so I can link Porphyria cutaneous tarda with biochemistry. Okay, so this is the heme synthesis pathway, this is the mitochondria, and this is cytoplasm. I know that there are a lot of pathways that actually use both because most of the time, di ba, cytoplasm lang or mitochondria lang. So this is one of the unique pathways. Ito actually siya lang yung isang pathway that starts with mitochondria, continues with the cytoplasm, and goes back again to the mitochondria. Most of the other metabolic processes, pwedeng mitochondria then cytoplasm at the end. Okay, cytoplasm to mitochondria. So urea cycle, gluconeogenesis, fatty acid synthesis, you can review that in biochemistry. They use both mitochondria and cytoplasm. But let's try to see what we can learn from this. Okay, so the Porphyria cutaneous tarda is here in the 5. Okay, there is problem with this enzyme. That's why I told you it's enzymatic rather than any autoimmune. Okay, so the uroporphyrinogen decarboxylase is lacking. Okay, the principle lagi is ganito. Kapag merong problem with an enzyme in this area, the structure or the molecule before that will increase, right? The amount. The molecule or the structure after that synthesis will decrease, right? So magbaback up yan papunta dito. So if this is affected, uroporphyrinogen will increase, this one will increase, increase. And then copro, protoporphyrin, heme will decrease, right? Okay, ganun lagi yung principle. So here we have a problem with uroporphyrinogen decarboxylase. So you have a low coproporphyrinogen, you have high uroporphyrinogen. Guys, itong porphyrinogen are actually colorless substance. Kapag na-oxidize sila, they can be conjugated double bond network and they become highly colored. Kapag in na yung ending, they're highly colored structure. Pag gen pa lang, they're colorless. Okay? So once these structures are exposed, like umihi ka with uroporphyrinogen, okay, and once this is exposed to oxygen, this will become like bloody or dark maroon colored. Maroon colored urine. That's why you have that presentation sometimes in PCT, apart from the photosensitivity. Okay. So let me see what I can teach you. So the PCT versus the AIP. So para maalala nyo lang, AIP, these are the two main problems with your heme synthesis. They have different actually enzymes affected. The porphobilinogen deaminase is what is affected in AIP. The uroporphyrinogen decarboxylase is what is affected in your PCT. Okay, let's look at them and let's try to see what is the difference. This is more on neurologic. This is more on cutaneous, so dermatologic, cutaneous tarda. So this is the affected enzyme. You have photosensitivity because it's cutaneous, right? So don't expect for a photosensitivity in AIP. You can have a red-brown to deep red urine, as what I have said. The ogen, which is colorless substance, once oxidized will become colored substance. And this is exacerbated by alcohol. Sorry, kulang ng D. Why? Because alcohol can actually affect the decarboxylation of the alcohol is hepatotoxic and will render the the liver incapacitated to decarboxylase this uroporphyrinogen. So instead na alcohol will worsen the deficiency of the decarboxylase, so it will aggravate the level of uroporphyrinogen in the blood. That's why the clinical presentation of this patient, alcoholic patient, adolescent, pagkatapos mag-board exam, na-frustrate kasi hindi nag-number 1 sa boards, uminom ng alcohol, the following day nag-exercise, poop, naarawan. And then the presentation is red urine and then photosensitivity, rashes, all those blisters. That's the clinical presentation of a PCT patient. Okay? And the clinical presentation of an acute intermittent porphyria is more on neurologic symptoms and abdominal pain. Okay? And they're exacerbated by barbiturates. Bakit naman barbiturates? Remember that barbiturates are inducers, right? In your pharmacology. So once inducers, what does inducers do in the body? They actually increase the metabolism of other substances. So in this case, they can increase the metabolism of heme. That's why heme can actually decrease in the presence of barbiturates. And remember, heme and glucose are actually negative feedback molecules for the starting point of this heme synthesis. Glycine is the simplest amino acid, right? Succinyl-CoA comes from your Krebs cycle. They combine with the help of vitamin B6. You can have the ALA. And then, yeah, the second enzyme here is actually, the first enzyme here is actually the rate limiting step. So, with the presence of heme and glucose, ito hindi yan magsasucceed producing all the necessary steps, doing all the steps. So, in the case of barbiturate intake, which is an inducer, the heme is inhibited. This is very low. Therefore, the inhibition of these two is also inhibited. So you have an increased glycine and succinyl interaction, and with the presence of vitamin B6, you have ALA. You have porphobilinogen. Okay, so tataas itong PBG mo. Meron ka ng problem with this enzyme, the third enzyme. Mataas na siya to begin with. Meron ka pang barbiturates intake that would induce this pathway. So you have exacerbation of PBG, aggravation of the level of PBG in the blood. That's why you have worsening. So symptoms of acute intermittent porphyria. So the clinical setting in this case, you have a patient who have seizures on barbiturates, okay, now presenting with psychiatric like what's this, abdominal pain and like psychotic symptoms on barbiturates with abdominal pain. This is a clue, abdominal pain with psychiatric symptoms with barbiturates plus a urine of port wine color. Okay, so that's a clinical presentation of AIP versus PCT. So they can be asked in psychiatry, in IM, dermatology, IM as well, or pathology. Okay, so another thing that I would want to teach you here in this pathway, since andito na tayo, if you can see, this is heme synthesis. So this is anemia. So if you have problems with any of the steps, you can have problems with production of heme, right? So you can identify three important causes of anemia here. You can have anemia if you have vitamin B6 deficiency, correct? You can have anemia if you have lead poisoning, okay? You can have anemia if you have iron deficiency, obviously. But they have different levels. They can be asked in biochemistry or in pathology. It depends on the levels that they give you, okay? You can pinpoint if this is lead poisoning, if this is iron deficiency, or if this is vitamin B6 deficiency. Let's start with vitamin B6 deficiency. So if I don't have vitamin B6 as a cofactor for the first step, the rate limiting step, subserved by aminolevulinate synthase, then I don't have everything, right? So you have low ALA, low protoporphyrin, low heme. So very easy. Vitamin B6, everything is low, correct? How about iron deficiency? If I have iron deficiency, I don't have any heme, but I have increased level of protoporphyrin, I have increased level of ALA, PBG, everything. Okay? So mababa to. Pero minsan, only this part, only protoporphyrin is increased, okay, in FE, okay, and then you don't have any affectation of the other steps, okay, kasi wala naman siya dun sa iba. But for lead poisoning, tingnan nyo to, if I have lead poisoning, I don't have the seventh step, the ferrochelatase, and also have the second step, the dehydratase. So what happens? I have increased protoporphyrin, and also I have increased ALA. Because the concept is, kung ano yung step na na-block, the previous molecule will increase, the next succeeding molecule will decrease, right? So vitamin B6, Mababa lahat. Iron deficiency, mataas si protoporphyrin. Lead poisoning, mataas si protoporphyrin and ALA. Let's see if you can correlate that with this slide. Okay, so iron deficiency, which is most common cause of anemia. You have microcytic anemia, mababa yung MCV mo. Okay, and then you have increased protoporphyrin. I hope you can connect that. You have increased protoporphyrin. You have normal ALA. Okay, normal ALA level, because even if it's like it's only the last step, I don't think it will back up here. So mataas pa rin yan. What is highest is your protoporphyrin. Okay, and you have decreased ferritin. Remember that ferritin is a storage form of your iron, and also you'd have decreased iron. Okay, so both of them are decreased, unlike in your anemia of chronic disease, so inflammatory anemia. Remember, the ferritin is high in that pathology, even if the iron is low. The reason behind is that cytokines will cause hepcidin production, and hepcidin will just allow your macrophage to keep the iron inside the cell, okay, inside the liver. So you have increased ferritin in anemia of chronic disease compared to your iron deficiency. That's the way to differentiate them. And sometimes the anemia of chronic disease, now the term is inflammatory anemia, not anemia of chronic disease, you have a normocytic cell, because actually the cells can actually compensate. For vitamin B6, that is most commonly seen in patients taking isoniazid. Kaya nga, di ba, kung meron kang isoniazid treatment for latent TB for 9 months, or for patients with active TB, you have to give pyridoxine, right? You also have microcytic here. You have decreased protoporphyrin. If you can recall why. Kasi nga, vitamin B6 wala, sila lahat wala. Okay? So decreased protoporphyrin. And you also have decreased ALA. Okay? Bakit mababa yung ALA? Kasi nga, vitamin B6 is not present as a cofactor in the first enzyme. You have increased ferritin. You don't have any problem with the storage of iron. Okay? You don't have any problem with the level of iron. Okay? As the same with lead poisoning. So in lead poisoning, you have here ring sideroblast in the bone marrow. Okay? Andun lang sila sa bone marrow. The sideroblast actually accumulation of those iron. They cannot be transported out. Kaya mataas sila dun. And then you have increased protoporphyrin in lead poisoning, as what we have seen. You have here increased this one and increased ALA. Okay, you have increased protoporphyrin, increased ALA, and both of these have normal ferritin or above, and increased serum iron. You don't have any problem with the levels of iron here, unlike in iron deficiency. Okay, so those are the things that we can get from this one slide. A lot of things, right? Heme synthesis, pathology, correlation, and biochemistry at the same time. And before we have a break, so this slide is memorable to me because I think I got one question. Yeah, I got it wrong. I answered one question wrongly during the board exam. Because they ask, I don't know if this is beneficial for you, but I'll just leave this here. Because they ask about one protein. Which of the following proteins or amino acids can actually lead to production of alpha ketoglutarate? Malay ko ba? Hindi ko naman maalala yan. Lahat ng dami-dami kaya nila. Diba? So, patsyamba na lang. Pero wala. Hindi ko na tsambahan. So, things to remember. There are certain glucogenic amino acids, ketogenic amino acids, both. So, ang pinakamadaling alalahanin yung both ketogenic, diba? Yung dalawang L na yan, they are both ketogenic, leucine and lysine. Okay? Very, very easy to memorize. Ang problema lang is itong both glucogenic and ketogenic and then glucogenic alone, medyo mahirap i-memorize. So I tried some mnemonics para maalala nyo. Ang minemorize ko lang itong both glucogenic and ketogenic. So the mnemonic here is try Philippine Islands. Thank you. Okay. Tri is for tryptophan. Okay. Philippines is for phenylalanine. Okay. Islands is isoleucine. Okay. And thank you, that's TY. It's tyrosine. So try Philippine Islands. Thank you. That's for both glucogenic and ketogenic amino acids. The rest are actually glucogenic. Sila yung pinakamadami. Kaya hindi ko na sila memorize. So, memorize ko lang yung ketogenic na dalawang L, leucine and lysine, and yung both glucogenic and ketogenic, try Philippine Islands TY. Okay, the rest is glucogenic. Ayos? Okay. So, can we have like 5 to 10 minute break? Para lang minom ako ng tubig, if it's fine.
Okay po, go kuya.
Sure.
Solid, solid.
Thank you.
Ayan, okay na kayo? Sige. Wait lang ha. Okay. Just a few tips for those who will be taking the boards. If you're confronted with a question about anemia, the very first thing that you look at sa labs is the ferritin, not the serum iron, not the TIPC. These are very misleading, okay? So look at the ferritin. If it's more than 100, this is a clue for you. If it's more than 100, it's very unlikely that it's iron deficiency anemia. Okay, 100 is the cutoff. Even in the presence of acute inflammatory infection, or even in the presence of connective tissue disease, the serum ferritin should be lower than 100 in iron deficiency anemia. Okay, unless there is one exception, unless the patient is an ESRD, that you can have some functional iron deficiency that 100 to 500 could be present in iron deficiency anemia in ESRD patient. Pero pag hindi sinabi ESRD patient, classic patient lang, tapos tinatanong ko kung anong pathology or anong problem, look at the ferritin first. If it's more than 100, then this is not iron deficiency anemia. If it's less than 100, kahit hindi mo na tingnan yung serum iron, kahit hindi mo na tingnan yung TIBC, if it's less than 100, 95 to 100% of the time, that's iron deficiency. Okay? And we're done with basic. So we're gonna move to thorax and clinical correlates for the rest of an hour. Let's see if we can learn something from here. Okay. So question, we can just do question and answer here, and then learn from the concepts. The presence of a tumor within the breast can distort what ligament, resulting in dimpling of the skin. Remember, that's one of the common presentation of a breast cancer, right? You have dimpling of the skin. You ask the patient to hold his hips and then bend forward. You see some asymmetry, okay? And then that is because this tumor actually can distort a ligament, okay? That's the Cooper ligament, right? Or you call suspensory ligament that attach the mammary gland to the skin and then run from the skin to the deep fascia, right? The inverted nipple presentation is not coming from this Cooper ligament problem. So if you have a question about an inverted nipple and then they ask you what is the problem, pathology, or like basic anatomy, this is the problem with your lactiferous sinus. Okay, so dimpling of the skin, Cooper ligaments, inverted nipple, lactiferous sinus, and this will explain. Okay, look at this suspensory ligaments. Okay, the Cooper ligaments, they can retract once this is invaded by metastatic lesions. They can pull the skin down to your pectoral wall. You can have dimpling, and then you have problems with your lactiferous sinus. You can have inverted nipples. Okay, remember those, because sometimes medical students or board examinees would confuse, what's the cause of dimpling versus the inversion of the nipple. This is a common board exam question in anatomy and even in surgery. So yun, binasa ko na. During a radical mastectomy, the blank nerve, sinabi na natin yun, the long thoracic nerve supplies what muscle which may be lesioned during ligation of the long thoracic artery. Remember that the long thoracic artery and the long thoracic nerve go together, right? And in radical mastectomy, that nerve could be lesioned, and the muscle involved is your serratus anterior, right? Which gives you the weakness of abduction of the arm above 90 degrees, and they can present with a winged scapula. If you still remember, you ask the patient to touch the wall, and you can see asymmetry of the scapula that's coming from paralysis of the serratus anterior because of the long thoracic nerve, ligation, okay? What nerve supplies your latissimus dorsi, which another case in mastectomy, resulting in weakness of the rotation of the arms, or even like abduction, medial rotation and extension of the arms. That is your thoracodorsal nerve. Okay, long thoracic nerve, winged scapula, thoracodorsal nerve, supplying latissimus dorsi, problem with their extension and medial rotation. Another board exam question for mastectomy is that paresthesia or numbness in the inner part of your upper arm. I think that's a lateral cutaneous brachial nerve that is also affected. It can also be ligated or be ligated in case of in the mastectomy, during the mastectomy procedure. So, but the most common nerves asked, thoracodorsal and long thoracic nerve. So, important role in metastasis of breast cancer. So we have two primary nodes. We have the axillary and your parasternal or internal thoracic nodes. Remember, this is the line that separates the distribution. This is very important because once you have a lesion in the middle part, this is a high likelihood of metastasizing to the opposite side via the internal thoracic nodes. Okay, compared to any malignancy or any malignant cells in the outer part or in the lateral part of the nipple, you only have not only but predominantly you can have metastasis to the axillary nodes than the parasternal lymph nodes. Okay, so higher metastasis to the opposite side if it's medial to this line that we draw, and then you have predominance to drainage to the axillary lymph nodes if you have lesions here on this side. And I hope you still remember the levels of the level of your lymph nodes in surgery. So here, level 1. So what is that structure that separates your levels? Level 1, level 2, level 3. It's not pectoralis major, but it's pectoralis minor. So inferior to the pectoralis minor, you have a level 1 lymph node. Underneath, that's level 2. Above it, superior to it, it's your level 3. Okay, so those are very important. Surgical correlation. Embryology again in lower respiratory system. There is what we call TEF in pediatrics, which is an abnormal connection between the trachea and the esophagus caused by the malformation of what structure? That is what you call your tracheoesophageal septum. Remember that in week 4, actually the lower respiratory tract system developed as a single diverticulum. Okay, and then they separate to separate the initial communication with the foregut. You know, this septum forms to separate them, the esophagus from the trachea, and without this without the obliteration of this septum, you have a communication between these two very important structures. And TF, the most common type in pediatrics, is type C, right? You have here an atretic esophagus proximal, and you have a distal TF. And what symptoms do you expect? So since you don't have a connection between the esophagus and the stomach, you can have regurgitation of the milk, and also you can have some gagging and cyanosis after feeding, because the gastric acids can actually reflux and can even cause, pneumonitis, because just remember the gastric acids going back to the lungs. Okay, this is the most common type C. Another embryology question. Pulmonary hypoplasia occurs when lung development is stunted, right? So there are two conditions that would give you those. So in pediatrics, they ask that. So the first one is a congenital diaphragmatic hernia. Why? Because of this hernia, this can compress one side of your lungs, and then can prevent its normal development, right? So it's most likely unilateral. We have two types of CDH. You have a left posterolateral side and also the retrosternal. The most common is this left posterolateral. We call it Bogdalic, if you remember. Okay, and retrosternal CDH is called Morgagni. Right? And the other congenital cause is your bilateral renal agenesis. Why? If you don't have kidneys, then you don't have urine. You cause oligohydramnios, which increases the pressure of the fetal thorax, right? Because this urine can actually cause caution. So if you don't have enough urine volume then you can actually cause pressure of the fetal thorax with any other organs. And that's what you call in pathology the Pater sequence, right? The bilateral renal agenesis causing oligohydramnios, causing pulmonary hypoplasia, bilateral in this case, right? So the difference in congenital diaphragmatic hernia, you have unilateral pulmonary hypoplasia. In bilateral renal agenesis, you have two sides. So you have a clue. So if you have a patient with a bilateral pulmonary hypoplasia, think about the kidneys. If you have a patient with only one-sided hypoplasia, think about hernia. Okay. This is very important. Anatomy and surgery. Passage of instruments through the intercostal space is done in what part of the space to avoid the intercostal neurovascular bundle. Remember that the intercostal neurovascular bundle is located in the bottom part of the rib, right? You have here, you have there the van sequence, the vein, artery, nerve from top to bottom, vein, intercostal vein at the top, intercostal artery, and then intercostal nerve. These three structures are located in the subcostal groove at the bottom part of the rib. So you want to avoid that structure. So the question is, what part of the space? You have to be very careful. We are talking about the space. We are not talking about the part of the rib. Because if the question is about what part of the rib, should you insert the instrument to avoid intercostal neurovascular bundle, then I would answer you have to insert it on top of the rib, right? But what part of the space? Okay, so I hope you get it's the inferior part of the space. Remember, the space is between two ribs. So I hope you imagine that one. You insert it on top of the rib, but you insert it at this inferior part of the space. So be very careful with the question because you might know the answer. However, you know, some of the terms are confusing. Okay. An intercostal nerve block. Okay, this time you have to target the nerve. So you want to insert it below the rib, right? Where the neurovascular bundle is. But this question is again about which part of the space. Okay, and it's on the upper portion of the space. So be very careful. You know the anatomy, imagine them so you can get to the correct answer. Respiratory distress syndrome is caused by deficiency of surfactant or type 2 pneumocytes. Okay, this is commonly asked in your pediatrics or OBGYN. What are the common causes of your RDS? Okay, the first one is very, very common, the prematurity, like the age of the patient, of the age of gestation is directly correlated to the maturity of the baby, and then indirectly related to the incidence of your RDS. So mas matanda si baby, or gestation mas mababa, indirectly correlated ang incidence ng RDS. So another one is because prematurity leads to inadequacy of the production of your surfactant or prematurity of your type 2 pneumocytes. Another one is your diabetic mothers. Infants of diabetic mothers are actually at risk of RDS, but infants of hypertensive patients are actually protective. Okay, so mas mababa ang incidence ng infants with hypertensive mother ng RDS compared to infants of diabetic mothers, because high insulin in diabetic mothers, antagonize the effects of your corticosteroids. That is important for maturing the pneumocytes type 2. And then the last one, if you have prolonged asphyxia, intrauterine asphyxia, then you also have premature production of your surfactant. So these are the three conditions. So if you have a prolonged labor, you have shoulder dystocia or any other complications of delivery that will prolong the delivery and causing asphyxia to the fetus, then you can have increased risk of RDS as well. Okay, on top of prematurity and the diabetes. So remember, hypertension is actually protective for RDS. Very weird, but that's the statistics. Inflammation of the parietal pleural layers. So we have a parietal and visceral layers, right? And in between you have the cavity. So if the parietal layer, which is the outside part of the pleural layer, is inflamed, it can cause a sharp pain upon respiration. That's why you call it pleuritic pain, right? And the costal inflammation produces local dermatome pain of the chest via what nerve? This is your intercostal nerve. This is the pathophysiology of your costochondritis or your pleurisy, or sometimes your pneumonia. You can irritate the the intercostal nerves, or even direct trauma. Okay? How about mediastinal irritation produces referred pain? So if you have like tumor in the mediastinum, or you have abscess, or you have mediastinitis, you can irritate this nerve. This nerve is called your phrenic nerve, right? And it can cause shoulder. Sorry, hindi ko na on yung aking camera. Ayun. Oh, yun. So mediastinal irritation produces referred pain via the phrenic nerve, because the phrenic nerve, goes in like on top of your fibrous pericardium, and it will cause irritation to your C3 and C5. Okay, that's why you have referred pain to your shoulder as well. This can also explain your gallbladder irritation, right? If you have gallbladder disease, you can have referred pain to the scapula and to your shoulder as well, or even like diaphragmatic irritation. You can have this one. Okay, phrenic nerve. So very important pleural reflections. You have the mid-clavicular line, the mid-axillary line, the paravertebral line. So just imagine mid-clavicular, mid-axillary, and paravertebral line. These pleural reflections are very important for you to estimate which part of the layer will you insert the instrument. So you have the visceral pleura. Remember, visceral pleura is directly adherent to your lungs. The parietal pleura is more on the outside part. So the space in between is the space, the pleural cavity, right? That is where you insert the needle if you would want to get like fluid, or if you would want to get any air in cases of pneumothorax, okay? So the visceral pleura ends at the 6th rib in the midclavicular line. So what I want you to do is just memorize the numbers 6, 8, 10, okay, for the visceral pleura. Of course, the visceral pleura should be higher, like in the level, but the numbers are lower, right? Because 6th is above 8. So 6th rib, that's the ending of your visceral pleura. The parietal is 8, just plus 2. Mid-axillary, it goes down and down, 8 and 10, and then paravertebral line, 10 and 12. So very important, because remember that the space is always below the rib. Okay, remember that, because you can be confused with like 6th space or 5th space that's below the 5th rib, right? So remember the 6th rib and the 8th rib, and the 10th and the 12th, because you can be asked about where to insert, whether it's mid-clavicular, mid-axillary, or paravertebral. But in case of pneumothorax, you can insert the instrument at a higher point, because air goes up. So 2nd to 3rd ICS is actually the ideal site for pneumothorax. But for fluids, you have to follow this number. So if I were to choose, then I can go to the 7th space, not the 8th space. Why? Because 8th space is below the 8th rib. It's already below the parietal pleura. That's why remember, space is below the rib. So I can insert at the 6th space, at the 7th space in the midclavicular line, but not at the 8th space. Yes, in the mid-axillary line, I can insert at the 8th and the 9th space, but not in the 10th ICS. In the paravertebral line at the back, I can insert at the 10th space and 11th space. Of course, there's no 12th ICS. Okay. I hope that's clear. So a tumor at the apex of the lungs, we call it Pancoast tumor, may result in this kind of syndrome. So most of the time, it's squamous, or not adenocarcinoma, more on the squamous lung carcinoma are commonly causing this Pancoast tumor. They can involve your thoracic outlet. That's why it's called thoracic outlet syndrome. So I just want to remind you about the thoracic outlet. So this is your brachial plexus, right? This is also your subclavian artery, and this is your subclavian vein. So the space formed by your anterior scalene and your posterior scalene, that's where your subclavian artery in the what's this, the brachial plexus inserts. That's the space, okay? And remember that the subclavian vein is on top of the anterior scalene. So if there is compression here, actually ang spare mo is the subclavian vein. Okay, so if there is a compression of the brachial plexus, most of the time, the subclavian artery is also affected. Okay, if you still remember, like the adhesion sign, that's actually the loss of the radial pulse once you rotate your head to the ipsilateral side when the neck is extended. Okay, after deep inspiration. So the pathophysiology of that is that you compress, especially if you have a tumor there, you compress this one subclavian artery. That's why you have loss of radial pulse. That's what you call the adson sign. Okay, and sometimes if it's too large, it can compress the superior vena cava. I mean the subclavian vein. It can also compress some of your cervical ganglion. You can have Horner syndrome at the same time. Okay, so just for you to remember. Now this one is more on the physical exam. This can be asked in IM. The superior lobe of the right lung projects the superior lobe of the right anteriorly, right? And above which rib? Above the fourth rib, and the middle lobe projects anteriorly below that same rib. Okay, this is very important because when you auscultate, you want to auscultate the upper lobe of the right lung or the upper lobe of the left lung. You have to auscultate above the fourth rib. Okay, for you to be sure that what you're listening to, for example, you will report decreased breath sounds or bronchial breath sounds or wheezing or rouse in the upper lobe of the right lung. You have to be sure that you're auscultating above the fourth rib because anatomically that is where it is. The middle lobe is below that one. So if you auscultate below the fourth rib in the right side, you are auscultating the middle lobe already. Okay. How about the inferior lobe of both lungs projects below the sixth rib, correct? Anteriorly and primarily projects to the posterior wall. Okay, so the border is the fourth and the sixth. So below the sixth rib, you're already auscultating the lower portion or the inferior lobe of both lungs. Remember that the left only has upper and lower lobe. The right has upper, middle, and lower lobes. Okay, so the border is fourth and the sixth. That's why sometimes you can also auscultate the inferior lobe posteriorly. Okay, so I just want to help you recall. So this is your oblique fissure. This is your horizontal fissure. You have 3 lobes in the right. You have 2 lobes in the left. So above this fourth rib, you're auscultating the upper lobe. Below the fourth, but above the sixth, you're auscultating the middle lobe. And below the sixth, posteriorly, you're auscultating your inferior lobe. In the left lung, it's only the sixth that the sixth rib actually demarcates your upper and then the lower lobes. Okay. This is a very easy question. I hope nobody gets wrong with this question. Aspiration of foreign body will more often enter the right main bronchus, right? Because it is shorter, it is wider, and more vertical than the left, right? Grade 1 na yan, anatomy. And when the individual is vertical, if like in my position, I'm sitting upright, and the foreign body usually falls into what segment of the right lower lobe? So you know it's the right lungs because it's wider and bigger and not and shorter. It's in the lower lobe, of course, because by gravity, the foreign body should go down to the lower lobe. However, what segment? This is talking about bronchopulmonary segment or tertiary segments. So this is more on the posterior basal segment. I would want to help you recall about these segments. So if you look at this, so this is the main bronchus, main left and main right. Okay, you have secondary bronchus. Okay, and you have tertiary. Okay, so tertiary bronchi, that's your bronchopulmonary bronchi. You have here the segments posterior basal. Okay, if you can look at this posterior basal Ito yung pinaka-vertical actually from this side. That's why most of the time, the foreign body will go down to the posterior basal. Okay? Kapag nakahiga ka, isipin mo yung dito na part. Okay? And if you are on the left side and the right, just imagine which side para ma-imagine mo. But the commonly asked question is this the posterior basal segment, which commonly is the which is the most common location of foreign body once you're upright. Okay? Pag bata, depende yan. Kasi most of the time, ito dito, most of the time, nag-right upper lobe consolidation sila pag aspiration in children, infants, actually, on a supine position. Kasi magkaiba yung kanilang anatomy ng apico-posterior or yan, ng anterior bronchopulmonary segments. Okay. So, yan. I want to remind you about your bronchopulmonary segments. You have 10 on the right. You have 8 on the left. You have 3 lobes. You have 2 lobes. Okay. And for it to become 8, malamang madalawa yung nag-combine, right? So the apico-posterior is combined. So these two are combined in your left lung. And then the anterior and medial is also combined here. That's why you have anteromedial in the left lower lobe. This is separated. Nasa likod pa tong medial side. Anterior basal, lateral basal, superior basal, and then the medial basal nasa likod na. So combined anteromedial basal is on the left side. Combined apico as posterior is also on the left side. So you have 8 and you have 10 bronchopulmonary segments. So itong mga bronchopulmonary segments are actually supplied by different lymphatics, different veins, right? And they can be removed. So kaya pwede kang mag-segmentectomy. Meron kang ano dyan, tumor, it can be removed without harming the other bronchopulmonary segments, since they are supplied by different lymphatics and veins. Okay. The lymphatic drainage from the lower lobe of the left lung, okay, also drains across the midline into what? Lymphatic trunk, right bronchomediastinal and nodes, then continues around the right pathway to the right lymphatic duct. I will show you because I know this is confusing. So just to remind you about the nodes that you have, this is the bronchopulmonary nodes. This is also called hilar nodes because it's located in the hilum, bronchopulmonary, between the bronchi and the lungs. So hilar nodes. Then you have the tracheobronchial nodes. So it's between the bronchi, in the bronchi and the trachea. That's why it's called tracheobronchial nodes. And you have the bronchomediastinal nodes. Okay? So if you have a lesion in the left lower lung, so pupunta siya dyan sa bronchopulmonary nodes, okay, aakyat siya dito sa tracheobronchial nodes, okay, and go to the left, the thoracic duct.
May heart, may ano. Yung, di ba sabi ko, walang nag-like kay Dimpo.
These bronchopulmonary nodes can actually travel to the tracheobronchial nodes and traverse to the other side. So itong left, if you have...
Kasi bagong parlor.
Sorry, nawala ako. So if you have a lesion in the left lower lung, this is very weird kasi apart from it going to that same side, it can also cross to the other side and go to the bronchomediastinal nodes to the right lymphatic duct. That's why if you have a cancer on the left lower lung, mas mabilis yung metastasis kasi unique yung kanyang pathway. It can use both ducts, right lymphatic and thoracic duct in the left. There's no such thing as left lymphatic duct, okay? It's called thoracic duct. Compared to like lesions located in any part of the lungs, like for example, you have a lesion in the left upper lung, dyan lang siya, on the left side. If you have a lesion on the right, you only use this one. If you have a lesion on the right lower lobe, you only use this one. So very unique in the left lower lung, commonly asked question, because they can use two pathways. They can use bronchopulmonary nodes on one side, on the other side as well. That's the question that's what the main point of this question. Okay, so if you have a left lower lobe lung mass, it has a higher incidence of metastasis and higher mortality. Okay, so reviewing your thoracic duct on the left is actually inserts between the left subclavian and the left internal jugular, as well as in the right lymphatic duct. And this is something that you have to recall. Everything is drained by the thoracic duct except for the upper part of the body, including the head, the left upper extremities, and the trunk. Okay, so ito sila lahat going to the right lymphatic duct. The rest goes to your thoracic duct. So pag meron kang, tinanong ka nila, meron kang wound dito sa right hand, saan siya magdi-drain? Malamang right lymphatic duct. Pag meron kang wound in the umbilicus, okay, it only drains in the left thoracic duct. If you have a wound in your, like, ito madali itong itanong at mag-confuse kayo. Like you have a wound in the right knee. Most of the students will answer right lymphatic duct as well. No, the right knee will drain to your thoracic duct. Just imagine this figure. Okay, the only exception to this is your left lower lung, because your left lower lung will drain to your thoracic duct. At the same time, it will cross to the other side and drain into your right lymphatic duct. Kaya mas mataas yung kanilang mortality. Mas mataas yung metastatic potential. Patients lacking dynein. I hope you still remember the dynein. Dr. Khan, DR, retrograde. They are involved in your microtubule, right, formation. And you can have eventually a problematic cilia. Or this is what you call the Cartaginer syndrome. And, you know, the triad, you have a chronic rhinosinusitis, you have bronchiectasis, and the situs inversus. Histology. The columnar and the goblet cells are sensitive to irritation. So the smokers have increased number of ciliated cells and submucosal glands, and this can lead to a ciliated epithelium transformation. We call it squamous metaplasia. This is commonly asked in pathology. Okay, meta means transformation of the epithelium from a ciliated to dapat columnar siya, di ba? Absorptive, nagiging flattened, and sometimes they become stratified, and that's the start of your any transformation can cause the dysplasia. After metaplasia, it can cause dysplasia, and then you can have carcinoma, right? And this one, bronchial metastatic tumors arise from this cell. Only few people know this one. It's your Kolchitsky cell, right? So actually there are a lot of names applied to this one. If I will just, they sometimes call it like diffuse neuroendocrine cells, or they call it APUD, or amino precursor uptake decarboxylate cells. But the most common is Kolchitsky. That's the endocrine cells of the lungs. Okay, and that's the most common source of your bronchial metastatic tumors. Okay, another application in pedia or pathology, cystic fibrosis, which results from abnormally thick mucus. So hindi lang sa lungs, pwede sa pancreas, can give you pancreatic insufficiency. In pediatrics, it can give you meconium ileus, right? Very thick ang kanilang secretions that even the motility is affected. This is in part due to the defective chloride transport by your Clara cells. Okay, so Clara cells is another cell apart from the Kolchitsky that you have to learn today that is involved in your cystic fibrosis. So these Clara cells are actually non-ciliated compared to your cilia, right? These are non-ciliated. These are bronchial secretory cells that they respond similarly to the cells once they are irritated. So kumakapal din sila, dumadami din sila once they are irritated. They detoxify, yun yung kanilang main function, and these are more commonly seen in the terminal bronchioles. So this is your terminal bronchiole, and these are your Clara cells, non-ciliated, but they act as the detoxifying cells, bronchiolar secretory cells. They are involved in your cystic fibrosis. Okay, so though the smokers or those living in the cities have increased number of Clara cells. This one, alveolar macrophages, okay, have several names, right? You have dust cells, okay, and then you also have names heart failure cells. So in almost all board exams, they always ask for macrophages. Okay, so walang board exam na walang macrophage. So I would want you to remember all the macrophages in the body. Okay, so I know I have collected all the things, all the macrophages in different parts of the body. They have just different names, but they act similarly. Okay, macrophage, phagocytosis. So let's try to recall them. So what is the macrophage system found in the skin? That is your Langerhans cells. Okay, iba po yung Langerlines, iba po yung Langhans cells. Ito, Langerhans cells. Okay, so if you remember the Langerlines, ito yung mga lines, di ba, we follow in surgery, cosmetics, to prevent yung pangit na contraction of the skin. Langhans giant cell, that's in pathology. That's more on your mga pathology that would give you giant cells, like TB, granulomatous pathology, right? This one is Langerhans cells. Okay, how about in connective tissues? We call them histiocytes. Okay, that's why meron kang histiocytosis. So those are problems with your macrophage system in the connective tissue. In the liver, what do you call these macrophages in the liver? We call it Kupffer cells. Okay, so ito yung mga makikita mong dark staining cells in your liver. In the placenta, what do you call these cells? I know medyo mahirap ng alalahanin. Those are your Hofbauer cells. So I just want to recall these things. The brain, I know we already mentioned this one. The old name is mesoglia because they come from the mesoderm. So these are your microglia, right? And yeah, they're the tiniest neuroglia we have in the brain. And in the lungs, we have already mentioned them, last cells or heart failure cells. Once they eat up those red blood cells, remember that in heart failure, you can have increased left atrial pressure, and then they back up to the lungs because of increased hydrostatic pressure, and they can go inside, extravasate into your alveolar cells, and then these macrophages will eat them up, so you have heart failure cells. In the kidneys, you have mesangial cells. Okay, that's your macrophage in the kidneys. And the bone, you have osteoclast. Remember those large cells, and then they will eat up the bone tissues that they can even leave this Hauschips lacunae, if you still remember. Parang space. If you see the osteoclast with the Hauschips lacunae, you're sure that you're seeing an osteoclast. In the bone marrow, the macrophage is your monocytes, which will transform into your macrophages, right? And then granulomatous, you have your epithelioid cells, right? These are your transformed macrophages, malalaki sila that you see, and then surrounding necrotic tissue, granuloma. And in the lymph nodes, you have sinus histiocytes. So these are all the macrophages that we have in the body. If you have if you have found any other additional, you can tell me so we can modify the slides and add them. But as far as I know, ito lang yung alam kong mga macrophages. So remember them. They can be asked in any subject, but most of the time this can be asked in anatomy and histology. So these are the macrophage in the body. Okay. So far, do you have any questions for thorax and lungs? Any issues or any problems? I think the last, very shortly before we end, is your heart and correlates. So madali na lang tong sa heart, konti na lang ata to. Actually, madami pang slides, pero I can give them everything. I can give all the slides to you guys. So mabilis lang to, 30 minutes. More on embryology and some histology in the heart. So I hope that we have tried to correlate, anatomy with different branches of sciences, pharma, pathology, OBGYN. I tried my best. Yun lang yung kayang i-link ng iba. So, napaka-interesting nitong heart. Kasi, parang single tube structure to before na nag-rotate lang. I just want to remind you about these things because these are very important in congenital heart diseases in pediatrics. So, you have here primitive ventricle. Basta makita mo yung primitive, guys. Ano yan sila? Very rough surfaces. They are the precursor for what you have an adult tissue. Primitive ventricle gives you the ventricle, left and right ventricles. You have primitive atrium, Basta may primitive na word, sila yung may mga rough surfaces. They can be trabeculated, they can be pectinated. So, di ba, pag trabeculae more on the ventricle, pectinate muscles more on the atrium. Okay? Near the rough surfaces, you have the smooth surfaces. The sinus venosus is a smooth surface. Okay? And the bulbus cordis as well is a smooth surface. Okay? And then above the bulbus cordis, you have the truncus arteriosus, okay, which is actually gives you both the aorta and the pulmonary trunk. So what happens is they actually dextrorotate. So itong green na to, they actually go forward, anterior to the right, while this one goes to the left and then posterior. So para siya nag-dextrorotate. So hanggang sa makita mo dito, that's ventral rotation. Ito magiging anterior, okay? At itong atrium mo parang papunta na siya sa likod. Correct? If you can see that one, it's more on the left. This is one is more on the right. That's why if you're asked about what is the structure most posterior, it's the atria. Most of the time, it's the left atria, right? That's why if you have any problems with your atria, you can have irritation of your esophagus because the esophagus is located just posterior to the atria. So if you have atrial enlargement, you can have some dysphagia and hoarseness because the recurrent laryngeal nerve also will be affected. So the most ventral aspect is this one, the truncus arteriosus, okay, and then the ventricles as well, okay, and then you have the smooth surface here, the bulbus cordis. You have the rough surface. You have the rough surface in the atria, and then you have some smooth surface from the sinus venosus. Okay, so all of these actually will divide into will septate into two halves, except for the sinus venosus. So itong atrium magiging left and right, ang primary ventricle magiging left and right, ang bulbus cordis magiging left and right, truncus arteriosus magiging left and right, except for the sinus venosus. So sinus venosus is the only structure that doesn't septate. Okay? So ito, commonly asked questions to. Ano, saan ang gagaling si aorta, saan ang gagaling si pulmonary trunk, and semilunar valves. Okay? If you can see here, this is the source of your truncus arteriosus, right? That's why kapag nagkaroon ka ng problem with that, you can have transposition. You can have persistent truncus arteriosus pag hindi sila nag-divide kasi dapat magde-divide sila. Okay? Sinabi ko kanina, kailangan sila mag-divide into left and right. Failure of division can have patent or persistent truncus arteriosus, right? So isa lang yung aorta at pulmonary trunk. Just imagine, isa lang yung galing sa right ventricle and galing sa left ventricle. Okay, so you have a mixed blood. That's why you have a cyanotic patient with patent or persistent truncus arteriosus. This one, the smooth part of the RV and the smooth part of the LV. So if you remember, right, this is the primitive ventricle. What is nearer is the bulbus cordis. Smooth yan, rough ang primitive ventricle. That's why the bulbus cordis gives you the smooth part of the right ventricle. In the adult, you call it conus arteriosus. In the left side, you call it aortic vestibule. Kasi ang left ventricle pupunta yan sa aorta, right? Ang RV pupunta yan sa pulmonary artery, kaya arteriosus. So the smooth part is coming from your bulbus cordis. The trabeculated part, madali lang to kasi nga rough surface, right? Primitive ventricles, correct? Hindi ka na magkakamali dyan. For the trabeculated part of the RA and LA, pectinate muscles yan kasi ito trabecular corneae. Pag atrium, musculi pectinati, right? So that is your primitive atrium. All the primitive will give you the rough parts. Okay, the smooth part, this one, the sinus venosus, sinabi ko, the only dilatation that does not become subdivided by a septum. Hindi siya nahahati. So the sinus venosus will give you the smooth part of the RA. Okay, sa taas to. Okay, and that is what we call sinus venarum sa adult. And then in the left sinus, kasi dalawang horns yan, if you can see right and left horns of the sinus venosus ito. So meron kang left horn and meron kang right horn. Okay? So ang left horn mo will become a coronary sinus. Okay? What is the role of coronary sinus? This is the main venous drainage of the heart. So if you will be asked in the board exam, saan ang gagaling ang main drainage of the coronary sinus? The answer is left sinus venosus. Sana hindi na itanong kung left or right. Kasi magkakagulo na. Okay? Basta the right will become the smooth part of the right atrium. Okay? Remember, the smooth part of the ventricles is bulbus cordis. You still remember kasi nga mas malapit siya sa ventricles. Okay? Ang atrium lang yung medyo complicated kasi magkakaiba. Yung right smooth part is coming from sinus venosus, and then the smooth part from the left atrium is coming from the pulmonary veins. That's why naka-asterisk yan kasi wala dito sa ating illustration prior. Right? So the pulmonary veins, which goes back to the left atrium, they are responsible for giving you the smooth part of the left atrium. The smooth part of the right atrium is coming from your right sinus venosus. Don't forget the coronary sinus. This is the main drainage system of the heart. Lahat ng veins pupunta dyan except for 3 veins that diretso siya dun sa right atrium. Hindi na siya dadaan sa coronary sinus. The smallest vein, the anterior veins, may isa pa, nakalimutan ko yung isa. Mamaya, tingnan natin. Okay? So, but most of the drainage system, most of the veins will drain to your coronary sinus before draining to the right atrium. The rest, yung mga smallest, not the small vein, small cardiac vein will drain to the coronary sinus, but the smallest cardiac vein will drain to the directly to the right atrium, as well as the anterior cardiac vein. This is commonly asked in the boards. So kaya nilagay ko rin siya. Changes after birth. In summary, kasi minsan nakakalito. Kung sino yung nagiging artery, a vein, sino nagiging ligamentum teres, sino nagiging ligamentum venosum, right? So closure of right and left umbilical arteries will give you the medial umbilical ligaments. If you still remember, we have 3 ligaments on the inner side of your abdomen. We have the middle, we have the medial, and we have the lateral. Okay, tatlo yan. Tatlong layers yan. So, ang median, that's coming from the urachus. Okay? Itong medial, ito yung nanggagaling dyan sa left and right renal arteries. The medial, yung pangalawa. Yung third, yung lateral umbilical ligaments is coming from inferior epigastric vessels. Remember? Yan yung border mo ng Hasselbalch's triangle para masabi mo, is it direct hernia or indirect hernia? Right? Kasi kung direct hernia siya, dapat in between the medial and the lateral, andun siya sa triangle na yun. Kung lateral to that inferior epigastric vessel, that's an indirect hernia. So, yeah, sana umabot tayo doon, pero hindi na. Feel ko hindi na. So, the closure of the umbilical, so this is artery, ha? Huwag kayong malito. This is artery. Closure of the right and left artery. Medial, not median, because the median comes from urachus. Kaya pag halimbawa may patent urachus ka, that's attached to your urogenital sinus, pwedeng lumabas yung ihi dun sa pusod mo. Kasi median siya. Medial is the lateral side of the median. Okay? Median, medial, lateral. Closure of the umbilical vein, you can have ligamentum teres of the liver. It's the round ligament of the liver. Okay? What is left is the umbilical vein. Okay, so this is the left umbilical vein. Yung right, nag-obliterate na yun earlier in the development. So the umbilical vein will become the ligamentum teres of the liver. The ductus venosus, remember this is the, para siyang segue. Instead na dadaan siya sa inferior, instead of the blood will come, umbilical vein, umbilical artery, dadaan muna sa, umbilical vein dadaan muna sa hepatic, that didiretso siya sa inferior vena cava via the ductus venosus. The ductus transform it to ligamentum. The venosus make it venosum. Okay. The foramen ovale will become fossa ovalis, and the ductus arteriosus will become ligamentum arteriosum. So lahat ng ductus will become ligamentum. Yung mga sus mo magiging sum. Okay. And then the foramen ovale will become your fossa ovalis in your adulthood. Okay, so these are commonly asked kasi nagkakalituhan dyan lagi. So remember these. The next slide, yeah, we're almost there. It's actually the atrial septation. This is the magic about endocardial cushion. I'll just tell you a story about this one. Kasi sinabi ko kanina, di ba, the neural crest is a very magical cell. They go to some parts, they spread, they induce other parts to develop. Okay, so ito yung story ng septation ng heart. So just imagine the endocardial cushion right in the middle. Para siyang notochord, right in the middle of the heart. This is involved in atrial septation kasi nga 'di ba hindi pa yan separated. Isang buong chamber pa yan. So it is involved in septation of the atrium, at the same time septation of the ventricle. So what happens is, the story is like this. This endocardial cushion, this is a love story between the septum primum and the endocardial cushion. Okay, so this septum primum is actually a flexible septum coming from the roof. Gusto niya makipagkita kay endocardial cushion. Okay, si endocardial cushion, paakyat ng paakyat, si septum primum pababa ng pababa. Pero sabi ni God, bawal kayong magkita, bawal kayong mag-meet kasi kailangan may butas dyan. Without the butas, kailangan, di ba? Kailangan natin ng patent because patency there because the blood from this side is is oxygenated. It should go to the left and then go up to the brain. Without that link, then the brain will not be supplied by any oxygenated blood. So alam ni God na kailangan patent yan, kaya sabi niya, bawal kayong magkita. However, matigas ang ulo ni septum primum at ni endocardial cushion. Bago sila magkita, merong butas ang tinatawag foramen primum or the first primary foramen. That's the foramen formed before septum primum and endocardial cushion would meet. Okay, matigas ang ulo, nag-meet sila. However, bago sila mag-meet, God is so wise, naglagay siya ng spontaneous hole or spontaneous hole formation mismo doon sa septum primum kasi alam niya na mag-meet itong dalawa. So while nag-meet sila, there is a small hole formed spontaneously. Hindi ma-explain. Spontaneous may be the function of the neural crest cells in order to maintain the patency between the communication between the right atrium and the left atrium. Okay? So meron pa ring butas. Okay? And yung pangalawang butas na yon is called your foramen secundum. Okay? Kaya tinawag siyang foramen secundum kasi pangalawang butas. Kasi yung first na butas, wala, na-overcome ng pag-iibigan ng dalawa. So, this foramen secundum is present. However, may isang bida-bida. Tingnan nyo. Another septum coming from the upper side, just beside the septum primum, but this time this is rigid. The first one is flexible. This one is rigid. And this septum secundum also wants to meet up with endocardial cushion. Ambisyoso din to. Sabi ni God, tama na kayo. Hindi na pwede talaga. Kasi pag nag-meet kayo, there's no way for the blood to pass from the right atrium to the left atrium. Because remember, this is a very rigid septum. And once it meets with endocardial cushion, wala nang butas. Remember, there is a spontaneous hole here, the foramen secundum. And the Lord was very intelligent that this septum secundum did not even meet up with the endocardial cushion. So it remains up there. Nasa taas lang siya while the hole is still present. Okay? So there could be problems like patent foramen ovale. Kasi ito naging foramen ovale, din fossa ovalis in adulthood. Itong area na to. Kapag masyadong malaki yung butas na hindi siya na-cover konti ni septum secundum, that's a patent foramen ovale, or masyadong maliit si septum secundum. Kasi saktong-sakto lang talaga that this septum secundum will just cover a little part of your foramen secundum. Exactly where iko-cover lang niya. Bakit, Doc, nagkakaroon ng communication? Because this is very rigid and this is very flexible. So a higher pressure on the right side will push this foramen secundum to the other side. Actually, hindi nga siya butas parang flexible lang siya na pwedeng mag-open up because of the pressure from this side to the other side. That's why there's a communication between RA and the LA. So papasok dyan yung blood, magpa-flap to the other side. However, after birth, right, as the baby inhales, okay, the lungs will now start to function and then the pulmonary vascular resistance go down. So dami ng blood papasok dyan sa left atrium. What happens is, instead of the blood going from right to left, now the pressure is higher on the left, and this flexible, okay, seemingly hole will actually bounce against the rigid septum secundum. Ito na, pag bounce niya, ito na yung magiging fossa, foramen ovale. Okay, na-imagine yun. So the limbus, or the border of the fossa ovalis, is coming from the septum secundum, pero yung floor niya is coming from the septum primum. Okay, and also magically, this endocardial cushion will meet up with this muscular part of the interventricular septum. This is responsible for forming the membranous part. Okay, yeah. Give me a second. Wait lang. Okay, so as you can see, this endocardial cushion is also responsible for forming the membranous part of the interventricular septum. So in cases of your Down syndrome, what is the most common heart defect in Down syndrome? Actually, the answer is endocardial cushion defect. So what do you expect in endocardial cushion defect? If this endocardial cushion will not go up, right, to meet with the septum primum, then you can have a patent, you can have an ASD, or atrial septal defect. If it doesn't go down to meet with the muscular part of the interventricular septum, you can also have a VSD. That's why in endocardial cushion defect, you can have both ASD and VSD. That's why the other term of endocardial cushion defect is atrioventricular septal defect. Okay, I hope that makes sense. So if you're asked about the most common congenital problem in Down syndrome, the answer is atrioseptal defect or endocardial cushion defect. If they will ask embryologically what's the problem, neural crest is the answer. Okay, so if you look at this, this is the fossa ovalis. As what I have told you, the floor of the fossa ovalis is coming from the septum primum. Diba? Ito yung nag-flap against the hard septum secundum. And the limbus, or the border of that, is coming from the septum secundum. Ito yung rigid part. So you can imagine the development there. This is the coronary sinus, where all the venous drainage goes except for the smallest cardiac vein and the anterior cardiac vein is coming from your left sinus venosus. Okay, and this is the ventricular. This is the ventricular formation of the septum. This is the membranous part. This is the muscular part. This is coming again from endocardial cushion. Okay. Another defect before I end. Yeah. So this is your coarctation of the aorta. If you would recall, this is more common in Turner syndrome, right? So we have two types of what's this? Coarctation of the aorta. You have a preductal type, which is common in infants, and also postductal type, which is common in adults. So more common is the adult type, the postductal. So the basis here is your ductus arteriosus. Okay, where is it found? So where is the constriction found? Is it found before the ductus arteriosus, that's preductal, or is the constriction happening or located after the ductus arteriosus? This is very important because the clinical presentation will differ, and more on the clinical presentation, so that you know if it's preductal or postductal. So in infants, if the constriction is before the patent ductus arteriosus, remember there's still some blood going down to the lower extremities, right? But this blood going down is actually deoxygenated, right? Deoxygenated from the right atrium, right ventricle, going up, and then instead of going to the lungs, some would go to the descending aorta, and then perfuse the lower extremities with deoxygenated blood. So in preductal coarctation of the aorta, you have cyanosis, correct? In postductal coarctation of the aorta, you don't have cyanosis first because the constriction is right after the patent ductus arteriosus. So very, very less amount of deoxygenated blood can actually perfuse the lower extremities. Okay, but if you will be asked which one of the two types has notching or rib notching is actually coming from collateral circulation. So this is the collateral, for example, this is the constriction part. They have to get a collateral circulation from the intercostal arteries, okay, and then to connect to the lower part of the descending aorta. This happens if you have a decreased perfusion, and this can only happen in postductal type. Kasi nga, wala ka ng perfusion sa baba, ay kailangan ko ng blood coming from the intercostal arteries. So nagkakaroon ka ng elaboration or accentuation of your intercostal arteries collateral circulation. That's why you have rib notching that you see. So rib notching is just like this. Yeah, if you can see that one. Rib notch, okay, because of the collateral circulation in the coarctation of aorta. So you only see this in the postductal type in adults. So in adults, you don't see any cyanosis, but you see rib notching. In infants, you have cyanosis, but you don't have any rib notching in the X-ray. Okay, and I hope you still remember your cardiology, histology. So this is your intercalated disc. As if you can recall, we have the gap junction. This is important, very important to communicate one cell to the other for unison function. We have branching, and then yeah, we have striations as well, if you can see. But the most unique feature is your intercalated disc. Okay, some few questions for the last 10 minutes. Let me see how many questions are there. Yeah, very few questions, just answering questions. So in MR, the most commonly involved artery is your left anterior descending artery or left interventricular artery. And then the second one is your right coronary artery. This will give you an inferior wall ischemia. That's what we have discussed the last time. And in 20% of the cases, you have the circumflex. Okay, so this one will give you a lateral wall ischemia. So in the EKG, you have affectation in the lateral wall, which is AVL, lead 1, V5, and V6, because they are more on the lateral side. This one can give you an anterior ischemia, like V2 to V4. This, the right coronary, can give you 2-3 AVF, inferior wall. Okay, the main vein in the coronary circulation is your coronary sinus, correct? It lies in the posterior coronary sulcus and drains to an opening in the right atrium, as what we have seen, that develops from the left sinus venosus. Okay, so these are practice questions that you can try to answer in 10 minutes. Let's see if we can answer them correctly. So all the veins of the heart drain to the coronary sinus, is what I have mentioned, except for great, middle, small, or anterior. Diba ang hirap tingnan? So, diretsahin na lang natin ang sagot dun sa para makita nyo. So all the veins of the heart drain to the right atrium through coronary sinus, except for the anterior cardiac vein. Okay, the great cardiac, the middle cardiac, the small will drain into the coronary sinus first, bago sila mag-drain into the right atrium, except for the anterior cardiac. So itong anterior cardiac, maliliit na veins, together with the smallest cardiac vein that drain directly into the right atrium. They will not use coronary sinus before they drain to the right atrium. The part of the conducting system found in the right atrium near the entrance of the SVC is your SA node, right? So that's where your SA node is located. And then which of the following structures forms the basis of electrical discontinuity between the myocardium of the atria and the ventricles? Remember, the atria should pump separately from the ventricles, because if they do, then you have a fibrillation, or you can have magkakaroon ka ng, because the atria usually should pump faster than the ventricles, okay? So they have to be separated. Kasi kung ano may nangyayaring arrhythmia sa atria, at least masispare mo yung ventricles. Right? So the cardiac skeleton is responsible for that. And from the placenta via the IVC, oxygenated blood in the RA would go directly to the LA by passing through which of the following structures? Of course, yung butas doon sa gitna, that's the foramen ovale. And in general, right coronary arteries supply which of the following structure? Right. So you can have AV node, SA node, kaya nga right predominant tayo kasi most of the nodes come, the supply is coming from the RCA and the right ventricle. Anterior LV is more coming from your LCA or left anterior descending artery. Okay, so which structure kapag nag-cardiopulmonary resuscitation ka? Compresses the posterior surface of the heart. Of course, anong nasa likod ng heart mo? Not the body of the sternum. This is anterior. IVCs, two posterior heads of the ribs is also ano na yan, likod na ng lungs. So the bodies of the thoracic vertebra lies right behind your heart. And a chest PA film, the right lower cardiac border is formed by, titingnan mo, right lower cardiac is formed by your right ventricle. And in the pericardiocentesis, paano mo siya gagawin if ever you have pericardial effusion? So insert the needle, subcostal angle directly to the left side. That's where you would use the access for pericardiocentesis. And the fossa valis of the heart is seen in which chamber? As what we have seen, it's in the right atrium, right? The fossa valis, the floor is coming from the septum primum. The limbus, or the covering, is coming from the septum secundum, and you only see this in the right atrium. And then a heart murmur was heard over the middle end of the second right ICS. It was probably coming from which valve? So I think we have discussed this the previous lecture. Right ICS, second right R aortic, right? Pulmonary L is for second left ICS. Tricuspid is in the left parasternal border around the fourth ICS, and mitral is in the fifth, in the midclavicular line, left. Okay, and the most anteriorly located great vessel, ito yung most commonly confused concept ng mga estudyante. Most commonly anteriorly located great vessel of the heart is the pulmonary artery. Once nag-divide yung aorta in the pulmonary artery via the aorticopulmonary septum, which is also induced by neural crest. So mas anterior yung pulmonary artery kaysa sa aorta. Okay? Ayan. So, kung titingnan mo, wait, give me a second. So, itong pulmonary artery mo, mas anterior yan sa aorta mo. So, pag sinaksak ka dyan, mauuna yung pulmonary artery mo mag-bleed than your aorta. Okay? Kaya, the pulmonic valve also has anterior, left and right. The aorta has posterior, left and right leaflets. Kaya, kasi ang aorta is posterior to the pulmonary artery. So, tatlo yung valves nila, tatlo. Pero ito right and left and anterior, ito aorta, right and left, posterior, by virtue of embryologic development. Okay? And that is also induced by your neural crest. So kung may problema ka with neural crest, may problema ka with endocardial cushion, you have problem with aorticopulmonary septum, problems ka with persistent truncus arteriosus, and even, the twisting, yung spiral fashion ng vessels mo. That can give you some transposition of the great vessels as well. That's why I've said neural crest is very magical in that way. So I think hanggang dun na lang kasi hindi na kaya ng ating time. So I think this is the time for you to ask questions. If you do have questions. If not, go lang. Okay?
May questions po ba? Pwedeng i-chat or yan. Pwede nyo i-on yung mga mic nyo.
Hold on. No, Daddy. Go down. Go to the other side. Go around.
Meron po ba questions?
Baka natulog na sila. Antok na kayo.
Another session ako to?
Sana may natutunan kayo guys, kahit pa konti-konti kasi ang dami talaga ng concepts ng medicine.
Siyempre naman, Kuya. Dami learning.
Okay.
Anyone? Wala? Sige, kuya, mukhang wala naman.
Okay, sure.
Ayan, tahimik sila.
Mag-pray na lang.
Ayan, okay. Opo. Okay, so kung wala na pong questions, I hope, ayan, wait lang. Ay, may mga thank you.
Thank you, sir.
Thank you po sa learnings today, Doc. Ayan. Okay, sige po. Bago tayo mag-end, Kuya Ken, nandiyan ka ba? Hindi ako maka-unmute. Okay, sige. Okay, so let's close our webinar tonight with a word of prayer. Okay, let's pray. Our loving Heavenly Father, we would like to thank you once again for making this webinar possible and for using different people po para nga po ma-push itong webinar tonight. Lord, may the things that we have learned will help us to be competent physicians someday, and patuloy na pong gabayan si Dr. Jerald sa kanyang patuloy na pag-share po and pag-i-impart ng knowledge and sa pagpapatuloy niyo rin po ng kanyang residency training. May you guide us, Lord, as we sleep tonight. We ask all these things in Jesus' name we pray. Amen. Okay. Thank you, guys.
Thank you, guys.
Kuya,
Thank you,
ibibigay
Kuya.
niyo daw ba yung PowerPoint na to?
Yeah, for sure.
Unmute
Yes.
na ako. Thank you, Kuya. Thank you.
Biglang na-unmute to si Kuya Ken.
Hindi.
Okay,
Na-lost ako
tapos
kanina.
na. Ewan ko sa'yo.
Andyan sila
Ayan, may mga-
Casey, Kuya.
Hindi, dito sa ano ako. Ila Banadjongjong Brondo.
Okay.
Sa Maryland.
Ayan, umuulan ng thank yous. Thank you, Kuya Jerald, for teaching
You're
us
welcome.
again.
Sana daw may next time.
Kaya,
Sana.
inabuso na.
Oh,
Sana. Let's see.
Ang next daw niyan, ikaw daw, Kuya Ken.
Oo.
Webinar.
Ikaw na, ibibigay ko lahat ng slides, tapos kayo na bahala
Oo.
mag-share.
Oh. See?
I-share ko tong slides. Wait, paano ba?
God bless sa duty mo next week. Pray natin si Dr. Pelayo, guys.
Oo nga.
And sa mga frontliners, syempre.
Back to the COVID.
Nitong pandemic na to.
Pababa naman ang kaso namin kahit pa paano. Slowly
Oh,
plateauing.
that's
Yeah.
nice. Okay.
Sana dumating sa point na wala na masyado. I-share ko to board review kay Abby.